Good morning, everyone. I know some people are still slowly coming in. This is our first venture of doing a patient symposium. I see a lot of my patients here and saw some from other folks on the faculty. And I'm figuring this is payback for us keeping you waiting all the time. So you're just slowly coming in, torturing me up here. But we're delighted you were able to make it. I'll be honest, I had a lot of anxiety over putting this program on because I've never done a patient-only symposium, ever. In fact, it's not been done at St. Vincent System. So the question was putting the faculty together, and I've got terrific people who are going to speak to you today, and then trying to get the word out. And getting the word out, to be honest, was the roughest part of all this. Just trying to let patients know there is something that we're trying to put on for them. But I've also asked Gabriel, who's a videographer who I've worked with before, to film the whole thing. So we will have some enduring material. We'll figure out the best place to put it. So for folks who couldn't make it, they'll still be able to see the educational content. I want to give a thanks to start with to, this is all being done through generous donations to a foundation that I set up for patient education. And I really, just to let you know, I want to give thanks to those people who kindly gave to this. In fact, one of them is there in the front row, my friend Mickey Maurer, who have generously given to this to the foundation that's set up to develop education for patients. Also wanted to thank actually my wife, who was helped me from the beginning to get this thing off the ground and sort of told me, yes, people will come. I got here early this morning, and there was not many people here, and I thought, oh my goodness, well, at least we'll videotape it, and you'll have it. But so y'all finally came in, and I appreciate that. And I really want to thank my faculty. You have to understand, they gave up this morning. They're all clinicians and could be doing clinical work, and no one's getting paid for this. The whole thing's being supported by the foundation. And I have nothing but admiration for all of them, and thank you. And I've seen all their talks, and I think you're really going to enjoy them. There is a talk, several people have asked me, is anybody going to talk about, healthy lifestyle and eating and so forth? And I said, well, that wouldn't be me. So, no, I'm not going to talk about that, but this skinny young doctor here is going to talk about that. So, anyway, thanks to everybody. Before I go into this, just a show of hands, if either you or someone in your family has atrial fibrillation. Yeah, that's exactly right. So it's the most common arrhythmia in the United States, and if treated appropriately, people can really live a nice, normal lifestyle, but unfortunately, a lot of folks don't really get treated appropriately. So let's go through this. So first of all, let's talk about the basic way the electrical system in the heart works. You can look at the heart as a four-room house. There's 2 upstairs rooms and 2 downstairs rooms. And if you were starting to walk upstairs, you'd go down the staircase. You could go to the right side of your house or to the left side. That's what the heart is. The heart has 4 chambers, 2 upper chambers, 2 lower chambers. An impulse starts at the top. It goes through its own staircase, the conducting system, to get to the bottom. And that provides a nice, normal rhythm of the heart. Atrial fibrillation is when the top chambers of the heart beat 400 or plus beats a minute. So just imagine that you're downstairs trying to watch a ball game, comfortably sitting there, and 400 kids are upstairs, all trying to get down at the same time. Now that would wreak havoc on everybody, right? So just like in the heart, you can't, if you go 400 beats a minute, you wouldn't be here today's symposium. I'm sorry, you would be somewhere not good. So the heart protects you. The heart has its own staircase to protect you. So you have all these beats on the top chamber, but only so many get through. But some people have a really good staircase, so many beats get through. Their hearts may go 130, 40, 50 beats a minute. Others not so good, but the cardinal feature of atrial fib is an irregular rhythm. So you can go really slow in atrial fib, but you'll see your pulse is never normal, or you could go fast, and they'll provide different symptoms for you. And we're going to talk about how to figure out this in a second. So what are the causes of atrial fibrillation? Well, the 2 most important causes are high blood pressure. Over 50% of people with atrial fibrillation have high blood pressure, and older age. As one gets older, there are changes that take place, anatomic changes in the top chambers of the heart, to cause a milieu, to cause a situation where atrial fib can come out. And it's estimated that about 10% of people 80 or older have atrial fibrillation. So it's a very common disorder. Caffeine does not cause atrial fib. If that's the one thing I can make your life easier on, people come to my office all the time, Doc, can I have coffee? Yes, you can have coffee. Now, we'll talk a little bit about caffeine later. There are other things it can do that may not be the best for you, but caffeine does not cause atrial fib. And what are the symptoms? It's funny, years ago, I was stunned a couple times by seeing patients come to see me with atrial fib, and I would put down palpitations and they wouldn't check it off. And it took me a long time to realize, you don't know what are palpitations, right? So the patient comes in the room and they say, well, Doc, I say, you don't have palpitations, really? And they say, no, but I got this flip-flop in my heart. It's like a fish jumping around, or it just doesn't feel right. So what we call palpitations, which is the medical term for it, is really just a feeling of unease in the heart. You know, and if you take your pulse, it's irregular, okay? So that's a common symptom, but there are lots of others. The most important thing is no symptoms. There are lots and lots of patients who have atrial fibrillation where it's what I call the annual office exam pickup. I see patients like this every week in my office. Many of you here may have had that happen to you or a family member. You go for your annual physical, you're feeling fine, and the doctor says you have an irregular rhythm, they get an electrocardiogram, and now you have atrial fib. How long you've had it, I don't know. It's one of the things we have to work out, and it's part of the treatment plan. But what you must understand, not feeling it doesn't mean it's not dangerous. It still has the dangers of stroke attached to it if you're at risk. And just because you don't feel it doesn't mean you shouldn't be treated. So here's the thing. Apple Watches are out there now, and they're very good, all these things. But here's what I'd like to teach you, okay? Everyone has their own actual watch, and it's called your pulse, okay? This is from ancient China. Moses Maimonides, in his early writings, talks about taking a pulse. So what I want you all to do, just do a little exercise here. I want you all to follow me and take your pulse. So here's how you do it. It's right here, right around your thumb. Just put your hand there and see if you feel your pulse. Okay? You feel it? If it's not atrial, if it's normal rhythm, it's nice, steady pulse. If it's bouncing around, you either need to see me afterwards, and I'll hang around, or see your other doctor, because that's probably not good. So you take your pulse twice a day. I'm crazy on this. My wife will tell you. I actually carry a blood. Yeah, my friends will tell you. I actually carry a blood thinner with me. Thankfully, I haven't had to take it because both of my parents had AFib, and one died from a stroke that was his first manifestation. So I take my pulse twice a day. I make sure it's regular, just 10 to 15 seconds. Just sit there, and if it's nice and steady, nothing to worry about. If it's bouncing around, you need to get evaluated. You don't have to. You can buy a watch if you want to spend the $400 or $500, or you can do this for nothing, twice a day. Take your pulse.
What do you do if, let's say, you go home and you take your pulse and you find out it's irregular? I mean, is that an appointment with your doctor, or is that a go to the hospital thing?
That's a good point. If it's Christmas Eve, you're probably not going to see your doctor. So if you're, I don't want to give you the wrong advice. I would say that if you take your pulse and it's irregular, take it again, let's say an hour later, it's still irregular, and you are at risk for stroke, and I'll show you the risk factors, I'd probably go to the emergency room and have it checked out. Yeah, I mean, stroke's a big deal. Yes, that's a good point. The most important way to take care of AFib is to preserve the brain. You need to know these rules. The reason you can get into trouble with AFib is you can develop a clot in the top chamber of the left side of the heart. It's called the left atrial appendage. It's there for a variety of reasons, but when blood flow is sluggish, you tend to develop clots. And if you develop a clot in that upper chamber and it dislodges, it will go most times to the brain. 23 to 25% of unknown strokes in elderly patients are found out to be due to atrial fib that was not diagnosed previously. And like my poor father, you can die from your first episode. So this is not fun and games. This is stuff that's really important. That's why I stress, if you don't know anything else, take your pulse. If you have an Apple Watch, they're pretty accurate. They overcall things. I mean, they'll call anything that's a regular AFib because that's what they do. But that's okay. At least you know something's going on. You can get help. This is actually looking with what we call an echocardiogram. Here's what I'm talking about. You see this big clot here? That's in this person's upper chamber. We had him immediately started on blood thinners, let it dissolve so that he wasn't at risk of a stroke. So are you at risk for a stroke? Well, it's based on a scoring system. It's called the CHA2DS2, and it's not perfect by any means. It's only about 60 to 65% predictive, but it's a good starting point. And each of these get weighted. So for example, if you have heart failure or hypertension or you're over 75, these all get weighted. If you have a score of 2, if you're a man, a score of 3 if you're a woman, because women are counted in there, but really it's a minor risk factor, it's been found out, then you are at about a 3 to 5% yearly risk of a stroke, if not attended to correctly, if you're not on a blood thinner. If you're on a blood thinner, you can ratchet that down by about 80 to 85%. So these are the things you see. I don't have, many of you are probably on some of these drugs. They're on TV all the time, right? They're always on TV. And then here's what it is. It's called direct-to-consumer advertising. It started years ago. And the problem with direct-to-consumer is that it's, you know, it's not like you can go order your own drug. And patients come in all the time and say, I saw this on TV. And Dr. Prystowsky, there's this big warning. You can bleed from these. They're blood thinners. Yeah, guess what? Their side effect is bleeding. I mean, that's what happens. Or you can prevent a stroke. So what would you rather lose? Blood cells, I mean brain cells, which are irreversible, or you have let's say a GI bleed, okay? Not fun, but it can be managed, and very, very few people ever die from that. So the overwhelming positivity is to take them. And which one you should be on and stuff is something that we could talk about later. I just want to make sure you're covered. And of course, Coumadin is fine to use. It's an old-time drug. It's just harder to take, has to be monitored. These drugs don't have to be monitored. So the most important thing if you have AFib is to get that right. Everything else comes to just feeling good. I mean, that's the one thing that could end your life or make you disabled for life. But there are other things you need to know about atrial fib. So one of them is, how do I keep the rate under control? And those are drugs we call either beta blockers or what we call calcium channel blockers. I've used Digitalis very uncommonly now, but beta blockers and calcium channel blockers. But here's the thing. Frequently, I'll see second and third opinions, and patients will say, well, I don't understand, Dr. Prystowsky. I've been treated with 2 drugs, and I'm still having AFib. Yeah, because these are the drugs that your PCP might be giving you with the mistaken understanding they will actually stop your AFib. They don't do that. Here's what they do. I'm going to give you an analogy that's, I think, a little easier to understand than trying to explain to you the AV node conduction system. So you just need to know, my wife helped me with this because I'm famously known not to cook at all. I basically know how to turn on a microwave occasionally, but I understand this is true. So if it's not, you can blame my wife. So imagine you're in a kitchen trying to strain something through a strainer, and the water's pouring through, and you have a strainer, and the water's coming out, right? So what could you do? You could say, all right, I'm going to put some plugs in there, and less water's going to come out. That may not be what you would do. Maybe you would turn off the water. You can't turn off AFib. So imagine you have 400 to 500 impulses flooding down into this strainer called the conduction system. So how do you have fewer get back down? You put some plugs in there. And those plugs are called beta blockers or calcium channel blockers. They do not stop AFib. They only slow the rate. That is not what the drug you need to be on if you're going to get yourself back to normal rhythm. Okay? Very important, because this happens all the time. I see this on a weekly basis. I don't know what to do, Dr. Prystowsky. All the drugs I'm taking have failed. No, actually, I love this because I have everything available to me now. You've been tried on nothing at this point, and we'll get you fixed. So these are the drugs, I won't go into them, that you use to try to keep your normal rhythm. We also have alternatives. I don't want to go into great detail, but we can try to fix you in a special electrical catheter lab by actually finding the sources of AFib and getting rid of them. Here's a good trivia question. So what is the only veins that carry oxygenated blood? Pulmonary veins, right? So blood, normally the veins carry deoxygenated blood back to the heart. Okay, that's what veins do. They go to the heart. And then you go to the lungs. And then the lungs bring the blood to the heart. but that blood is oxygenated blood. So the pulmonary veins are critically important for that function. But around the veins are muscles. And it's been found out that these muscle areas are the typical spot for AFib. And here you can see in the lab, here's someone in a nice normal rhythm, and they suddenly go out of rhythm. And here's a catheter sitting in a vein, and you can see how the electrical activity just starts going haywire. So what we do in the lab as an alternative to drugs, but it's an individual thing, it's not one better than the other. We go in the lab and we wall off the veins. You can see these red lines here. And when you wall off the veins, in most people, the AFib stops. And you can see it stops here. So there are alternatives. It's too complicated to go through today, but you need to know this. And when you see your cardiologist or electrophysiologist, you need to be armed with this information. Which drugs do I need to be on? First and foremost, prevent a stroke. And then try to make you feel better. Do you want to be in normal rhythm or not? If you're not, you don't care about being in normal rhythm, at least make sure the rate's controlled so you have a decent lifestyle. If you want to be back in normal rhythm, you have to consider these other drugs. But that's a discussion that you're going to have with your specialist. So before I end, I wanted to cover two other areas. So let's talk about palpitations. Because I get pulled aside at almost every event I go by somebody who says to me, Eric, I'm feeling these extra beats. What do I do? I'm scared. And it is a scary feeling because you don't know if that's something that could cause you to drop dead. And you always hear about, Billy was fine until they found him dead in bed. So no, it's the problem with sudden death. Sudden death is just that. It's the sudden, unexpected demise of a patient. There was just recently a sad case in our own hospital. I just got word yesterday, one of the pediatric endocrinologists was found dead. He's had sudden death. You always read about somebody playing ball, okay, and they die suddenly on the field. So when should you worry? If you're just having flip-flops, skip beats, occasional, jump in a pulse, or your heart you think is racing, but it's less than 100 a minute, that's hardly ever anything to worry about. Now, it may be life-disturbing. You may want it to stop, so then you have to see someone that can analyze what it is and give you the right medicines, but it's not life-threatening. These are the things that you need to worry a little bit about. Let's say you're a little lightheaded and you take your pulse. You know how to do that now, right? You take your pulse and, oh my God, it's 20 beats a minute. That's not good. Now, you need to see somebody. You're maybe in heart block or there's something going on. You need to see someone. Or you don't feel good and you take your pulse and you're going 180 a minute. That's not good, right? You shouldn't go 180 a minute sitting there relaxing. Even if you're excited, you don't go 180 a minute. If you have a fast heart rate, an irregular heart rate, a really slow rate, those are the danger signs, and you need to see someone. And for this young lady back here, yes, if your doctor's not there, call the emergency room. There's one of those there. Just to stay on tight, right? Since you want to know what, those are the ones where you do need to worry. If it's skipping, just a skip beat, no. You can sit and wait till Monday and call the office. Dizziness is a common symptom, but it's not just about dizziness. You have to know there's a differential here. There's a difference between dizziness, lightheadedness, and passing out. True dizziness, like the room spinning or you're spinning, is almost never due to heart conditions. It's inner ear, it's in the brain. Now, I know you'll call my office and say, I'm feeling dizzy, I want to be seen today. I've instructed Marilyn, who's going to speak later back there, my Uber nurse, to always find out, is the room spinning? Are you spinning? Or are you actually feeling like you're going to pass out? If you're feeling like you're going to pass out, I need to see you. If the room's spinning, call your favorite ENT person, because it's almost always an ear problem. Lightheaded is different. Lightheaded is that feeling like, geez, I'm going to pass out. Not spinning. It's a graying out feeling. I'm just not there. That's usually blood pressure, but it could be a heart rhythm. So that has to be investigated. And if you actually pass out, if you literally pass out, you need to be investigated. Now, oftentimes it's nothing. I mean, it's just a blood pressure issue, or you had, some people get what's called a vagal spell, but it has to be investigated. So don't mess around with those. So lightheaded and syncope, you need to take seriously. Room spinning, see your ENT or PCP or something. It's hardly ever the heart. So I have some questions I booked in, but I'm going to stop and let you all ask. If you have questions, we'll do that. I booked some in if you didn't have any, but we have some microphones, and I'm happy to take questions from the floor. Yes? Do we have those mics? Or, well, go ahead. I'll repeat it.
Try to yell, because I'm sure other people have experienced that too. I had breathing problems, and whatever I did didn't help any, until I went to my cardiologist, and he gave me a blood thinner because I had been in AFib, and all of a sudden I could breathe again. It seemed like a miracle to me, and I wonder, was it really due to my heart, or what happened? Was it?
Well, since I have all your medical data in front of me, I mean, well, it was not due to your blood thinner. It's the only thing I can actually tell you. I'm glad you're on a blood thinner. That's appropriate. But blood thinners don't have anything to do with how you're breathing. So you sure that's all your doctor did? Just gave you a blood thinner? He didn't give you anything else?
Well, he took me off one medication.
Well, okay. That you shouldn't have been on, right? So Dr. Hermel is going to talk a little bit about the differential for shortness of breath, so I don't want to go into that. But shortness of breath does have to be investigated, but I'm going to leave that to Dr. Hermel because it fits more in his talk. Blood thinners do not affect breathing, no. But you know, you could say they do in a sense. If you stay alive, then it does affect breathing, right? Versus dropping dead from a stroke. So I guess in a sort of a funny way it affects breathing, but no. But I'm glad you feel better. That's great. Any other? Yes, ma'am. I'm sorry? Ablation, yes. Well, that was what I was showing you. That's called an ablation, I'm sorry. With the mechanical way when we isolate. Yes, catheter ablation is absolutely useful. There's been a recent study that shows that if you compare drugs to ablation, they have equal downsides. I mean, major complications were actually the same long term. But catheter ablation is much more effective in keeping people in sinus rhythm. That's a discussion you need to have actually with an electrophysiologist, somebody like does what we do. That's really not a discussion that even cardiologists can get into. It's pretty specialized, and it's not for everybody. So you have to, a lot of folks are sent to me for opinions about ablation. I do not ablate all those people. I mean, there are many people where it's not the best choice. So, but that's what the isolation technique's called. Yes, it's nice to have. I have a fellow who sent me a picture. He was having terrible times with his AFib, and we ablated him, and fortunately it worked. He sent me a picture from base camp in Nepal. He didn't go all the way up to Mount Everest, but he's sitting there, and he has a sign on here, "I'm AFib free." He said, "You can use this in all your lectures." There's a HIPAA regulation against that. I said, but I was pleased. Yes, it does work. When it works well. You're off of most of your drugs, not necessarily blood thinners, but you're off of all the other drugs. But again, it's not for everybody, and it's a really detailed discussion in the office because it's pretty high-tech stuff, and you have to know the goods and bads. But it is a very successful technique. Yes, sir.
Is the term heart murmur and AFib interchangeable?
No.
Yes or no?
The answer is no, and the heart murmur part of that, I'm going to let Dr. Hermiller talk about because it's a very important issue you raise. Heart valvular problem can lead to atrial fib. You going to cover that, Herms? All right, so we're going to wait for Dr. Hermiller's talk. He's next to talk about that. But yes, they're not interchangeable, but they do coincide. Yes, I'll get to you, but yeah.
I'm taking no medication. I have no health problems whatsoever. About 6 months ago, I had my physical. Nothing out of the ordinary showed up. In the last couple of months, I've noticed several times that in my heart area, it was almost as if there was an electrical. I was still beating normally. I didn't.
You don't have a device.
Huh?
You don't have like a pacemaker or anything.
No, I have nothing. No.
So, and you haven't seen a psychiatrist. No, I'm kidding. It's just a joke. It's just a joke.
It just felt really strange. Like
Yeah. So I know what you're saying. You feel like a sudden kind of almost like electrical sensation. Well, you have to understand, and people do get worried about that. Dr. Hermel will probably talk about when to worry about chest pain or not. No. But the thing is, you can have a muscle twitch. I mean, people get those all the time. It's called a muscle stick, and you'll suddenly have for a second or two like something, and you go, oh my God. As I'm sure Dr. Hermel is going to tell you, true cardiac pain isn't 3 seconds, okay? I mean, there's stuff to worry about. So feeling like a brief something or other is rarely anything to worry about, okay? A couple hours. Well, the thing is, here's the interesting thing. A couple hours is usually not something to worry. I mean, I know it sounds like we're talking bookends, but when a patient comes and says, I've had chest pain for 2 days, unless there's something really, really bad going on, it's usually not cardiac. And if it occurs for a few seconds, it's not. As Dr. Hermel will tell you, there's this spectrum in there, and he's going to go over when to worry and when to hold them, when to fold them kind of thing. But what you're telling me there, without knowing or anything else, I would tell you, if that's the sole thing, I'd get it checked out, but I would doubt if it turns out to be cardiac. Yes, sir. And then I'll get to you, I promise. Yeah.
Can sleep apnea have any effect on cardiac health?
Yes. You saw I was up there, actually. I was going to get to that. And you're actually sitting at a table with someone who you should talk to afterwards. He's sitting right across from you there because it's his area of expertise. Sleep apnea, in my personal experience, does not cause atrial fib, but it can clearly make it worse. And the signs are this. But you got to be careful as a doctor in the office. I'll give you a very quick vignette. I always ask the patients if they snore, because they don't know if they're snoring. They're asleep, right? So you have to ask the spouse, are you snoring? Well, one day, I had a man and a woman, and it was the woman who was there for her atrial fib. And I said, do you snore? And she said, no. And he turns to her and says, honey, you snore all the time. And at which point, a fight started. I actually had to leave I'm not kidding, I actually had to leave the room. She started screaming at him that was unladylike, and how could I tell the doctor that? I said, I'll be back in a couple minutes, guys, just work it out. So in my personal experience, it does not cause AFib, but it can clearly make it worse. And the clinical signs are people who tend to wake up with AFib. Right, Harold? They tend to wake up with it. And there is a treatment for it, okay? You can get these, we call CPAP, but Dr. Smith actually can make a mouthpiece for you, and if you're able to. You can't do it for everybody, but what I'm saying is you should worry about sleep apnea regardless of the AFib, but if you have AFib, it should be attended to. It can also cause hypertension, it can cause pulmonary hypertension, there's a lot of reasons. And often you just don't feel good during the day, right? You're dragging, so it can make you feel better. So regardless, you should attend to it. I can take that one more question and then I'm going to turn it over. Yes, sir.
I am prone to have AFib. If you have AFib, you are suggested to take exercise, but if you do too much exercise, it can put you back into AFib.
What's the deal? Well, like I told you, I'm not your exercise guru. That's your exercise guru. But I will tell you this. You're easy to treat, actually. I mean, you just have to get to the right doctor. If there's a clear-cut inciting cause for AFib, you can usually tailor your therapy. For example, I have patients who are long-distance bike ride. They do 30, 40 miles. And then they'll tend to go in AFib. They don't want to be on a beta blocker because you feel draggy, especially they tend to have a slow heart rate. So I do spot therapy for them. So a half hour before they start their bike ride, I have them take a certain amount of beta blocker to just keep the sympathetic tone down. And 4 hours later it's gone and you can avoid AFib. So you just need to get to someone who understands AFib. And that's actually very approachable as far as therapy goes. Well, I'm going to have to stop the questions. I thank you very much for your attention, and I'm going to bring up Dr. Hermler. Dr. Hermler, just as a way of introduction for those of you who don't know him, is our chief interventionalist. He's a fellow Dookie, so that's good, okay? Until basketball season, then you hate both of us, I understand. He's also got himself into this area called structural heart disease, which are these really cool valve implants. And he and I see a lot of patients together. He's not only a wonderful speaker, he's an outstanding doctor. So listen to what he says.
All right, thanks. Thanks. Hey, this is, it is great to be here today. And I wanted to thank Eric for putting this together. I think this is a fantastic idea. And also Suzanne for all the heavy lifting. And Eric's the electrician, I'm the plumber, so I'm going to sort of talk about plumbing issues here, okay? I will try not to kill you with too many slides, all right? It will not be death by PowerPoint here. And I don't think maybe I have one slide that's a graph. That's it, nothing else. So we're going to talk about chest pain. Is it really my heart or not? Shortness of breath, could it be my heart? And then we're going to talk briefly about, I take blood thinners, and we just talked about it a bunch, but I'm bleeding. Is there anything I can do about that? Is there any alternative? I'd say if you look at symptoms that people come in with, chest pain, shortness of breath, and then probably dizziness, and a cramp here and there. Those are the most common ones, all right? And so we'll start with chest pain because it's so common and yet it is so important that it's recognized for what it is. So if you look at chest pain and heart disease, right, this is what scares people. And it's incredible that with heart disease and blockages of the arteries to the heart, you can have pain from the top of your head down to your navel, and it may be the heart, okay? It be quite variable from patient to patient. It turns out that when I get coronary disease, it may be my arm that hurts when I exercise. If somebody else has it, it may be, a Hollywood heart attack, a big old elephant on the chest. Once you have a heart pain, you know what it is, and it doesn't change over time. But that first time you present with a symptom that's due to blockage of your heart, that's the most dangerous because people usually don't recognize it for what it is. Once you have a heart attack, you know what it is, and you won't miss it the next time. So what are some of the kind of tips that tell you, hey, this may well be my heart? So it tends to be central. The more it's centrally located, the more likely it is your heart. Your heart's right behind your sternum. It's not over here to your left side of your chest. So that's one thing. The higher it is up in the chest, the more likely it is your heart, okay? Heart pain, as Eric said, it isn't something that's there for a couple seconds, a buzz, a sharp pain. It has some duration to it, but it doesn't go on for days. If it goes on for days, you're dead. So, you're not going to come in to be seen. The other kind of factor is it tends to be exertional, right? That's when the heart wants a lot of blood flow. So if you're having some symptoms at rest and yet you go out and you can run for 5 miles and you feel great, that's not your heart, okay? It's something else. So exertion is a good thing to pivot off of. And then the quality of the pain. Occasionally it can be sharp, but it's typically not sharp. Sometimes it can be burning, okay? And I can remember being an intern, going to the pharmacy, being called to a cardiac arrest, and there's the patient with Maalox around their mouth. They thought it was their GERD, thought it was their hiatal hernia. So sometimes it can be burning. Often it's just dull in nature, okay? You have any of these symptoms, you need to see your doctor, particularly if you've never had any heart disease, because who knows? It can, I can't tell you how many people have heart attacks in the dental chair because they've got jaw pain, right? That's their heart. That's their heart. So pretty much anything from here to there can potentially be your heart. Now, who is it that may have atypical symptoms? Women certainly do, but I'll tell you, women frequently have the same symptoms, they're just ignored. There's this perception that women don't have heart disease. They don't die from heart disease, they die from breast cancer. Heart disease is the #1 killer, okay? So frequently the symptoms are just ignored, but they may be a little more atypical. One of the symptoms that we'll talk about is shortness of breath. Frequently that's all people have. It's shortness of breath due to their blockage of their hearts. Diabetics often don't even have any symptoms. And if you look at them, 20% don't have any symptoms before a heart attack. So just give you some lay of the land with respect to chest pain and how to look at it. So the one that we're worried about, of course, is you've got blockages in the arteries, right? Some of those big, beautiful donuts out there end up in your coronaries and cause blockage. And, unfortunately, you don't have a lot of symptoms beforehand. Probably half of people don't have any symptoms except for the week before it. And you have a heart attack before it because you form a clot on top of that plaque very quickly. So you sort of have to, if you get substernal pain, it's bad, you start to sweat, it's time to call the ambulance, all right? That's another thing to take home. If you think you're having a heart attack, don't get in the car, call the ambulance. Over and over, we see people, they try and drive in, they drop dead in the car on the way in, You have a cardiac arrhythmia, you don't make it. If you're in the ambulance, they can shock you and bring you back. So call the ambulance, don't try and drive yourself. So if you do come in with chest pain and we think it potentially could be your heart, it's not something else, what do? Stress test is probably the first study that we would do along with an EKG. You don't have to run. If you can't run, there's all kinds of ways to do this with a chemical test, so you don't have to run. These days, we can actually do a CT. We'll talk a little bit about CT scoring later. But you can actually do a cath, essentially, by doing a CT with angiography. And we'll also often do ultrasound to look at the heart function. If we think you've got coronary disease, you may get a heart cath, okay? And these days, a heart cath, 95% of the times, we just go through the wrist to do it. So it's sort of amazing. In this particular patient, right here, this is all the blood flow to the heart. They've got the left main here. That's the widowmaker. All the arteries are busted here. And that's why this little cute kid's going, what in the hell? That looks bad. If you do have some blockage, there's 3 treatments. You could get medicine. You could get a stent that goes inside there to prop it open. Or you might need open heart surgery to do bypass surgery. You know, in this patient, they were elderly, so this is a few stents in there, and now it's wide open. You can see the difference between how open this is and how tight that is. Now, if it's not your heart, what else can it be? It can be anything in your chest or abdomen, right? Esophageal disease, hiatal hernia, GERD, frequently is a cause. You can get esophageal spasm. It can be everything like the heart. Your brain can't tell the esophagus from the heart many times. And that pain will get better with nitroglycerin. It could be gallbladder disease. It could be your pancreas. It could be lung, pleurisy, pneumonia. You can have a clot go to the lung. Or it can be the chest wall, arthritis, sternum, muscle, you pulled something. So there's lots of causes for it that are not necessarily the heart, but assume it's the heart until somebody tells you it's not. Okay? All right. Let's talk about shortness of breath, all right? We're going to talk about risk factors later. I do love, we see patients all the time that come in. What do you think, am I at risk? Hell yes, you are, you know? So shortness of breath, yeah. This is really common, okay? This is really common too. Frequently, it can be the lungs, right? That's probably the most common. Asthma, you've got COPD, somebody that's smoked or they've been exposed to some sort of chemicals in the past that their lungs aren't working correctly. Clots go into lungs, that can cause you to be short of breath. If you get anemic, if your blood count's low, often you're short of breath. That's your symptom. Or it can be your heart, and I'll tell you, frequently, whether it's blockage of the arteries, the heart's not pumping correctly, there's some problem with the valves, it's shortness of breath that people have. So if you're short of breath, all the things I said about chest pain are very applicable to shortness of breath. It can be the first sign, and often is the first sign of heart disease. One of the reasons you get short of breath is your valves may not work, right? We all have 4 valves. They allow the blood to go the right way, and particularly the valves in the left heart, which is the main pumper, the mitral valve and the aortic valve. When they don't work, when they're leaking or they're tight, they can cause all kinds of trouble, okay? So blood comes back from the lungs, it goes through the mitral valve right here that's got 2 flaps, and then it'll go through the aortic valve up top that looks like a Mercedes-Benz sign, okay? Frequently, valve disease is present in causing shortness of breath, and it's related to age, right? There's actually an epidemic of valvular disease because we're all living so long. I mean, our offices now, used to be, I hardly ever see anybody 90. It's all the time, you know, and now 100-year-olds come on in, all right? And valve disease, as you get less young, is much more common, okay? And when you tell somebody, you know, they're 100 and there's nothing to do, that's what they think about it. So lots and lots of patients with valve disease. Just remember that. And, you know, we'll talk about this, but the oldest patient, we did an aortic valve replacement through a catheter, 101 when we did him. He's now 104 and a half. He still gets on the treadmill every day and walks, and he takes a baby aspirin. That's it, okay? So there, you know, just because you're 90 is not a reason to give up, okay? The most common thing is this aortic stenosis that I talked about. That's the one that looks like Mercedes-Benz. On top is a good one. On the bottom, that's one that's all blocked up with calcium, okay? Gets all calcified, blocked up. Blood backs up into your lungs, you're short of breath. That's what people come in with, often just exertional fatigue. And it used to be, you know, you'd have to have open heart surgery, crack your sternum, replace that valve. There's some really good sound that goes with this. It's not on. These days, we can actually come up from the leg. It's like putting a stent in, okay? We come up, there's a valve, there's a balloon inside that valve, and much like a stent that we put in, we basically blow that balloon up, and the valve comes up and moves the old one out of the way, okay? And we pull that out, and back to the room, up, walking around later that afternoon, and most people go home the next day. You know, it's kind of amazing technology. Generally, people moo after this, mostly cow stuff, but occasionally they oink and it's a pig tissue valve. What else could potentially cause shortness of breath? Okay? Being overweight, not exercising causes shortness of breath, period. Okay? And often that is the reason, and it's hard to admit that's the reason, but that's the reason for being short of breath. There's a really, great doctor in town, and he's very famous, and he got short of breath, and he went all over town. He had every test known to man except for an autopsy. And finally, he comes in to see me and says, "I'm short of breath. Nobody can figure it out. Can you figure it out?" I said, "Mark, you've upped 40 pounds. You're short of breath because you're fat." And he said, "You're wrong. I'm going to lose it, and I'll be back. And then you can figure it out." And he came back in. He come in, and he said, "Shit, you were right." So losing weight will make your shortness of breath get better generally. Okay, finally, let's just talk about bleeding on blood thinner. We've talked about blood thinners. Eric just did a wonderful job. There's all kinds. I'm going to focus basically on the ones for atrial fib, but there's others after you get a stent, Plavix and aspirin. We could touch on that as well. And he's already hit on it. You got to take it to prevent a stroke. Unfortunately, a lot of people bleed on it, and they can't take it. So what do you do? Are there any alternatives to that? This is what a clot looks like in that darn appendage. Why God gave us that appendage, who knows? It's kind of like your appendix. It causes trouble and doesn't seem to have much value. So that's that place where those clots come, that appendage. It's a useless thing, like that sign not in use, or kind of this toilet paper invention, right? So they're useless. And there is an alternative. There's a way to put a plug in that to prevent those clots from coming out of there, and this is sort of the Watchman procedure. We put a little tube from the leg that comes up into that appendage, and then we drop that plug in there. And then that plug isolates the appendage, and it prevents any strokes related to atrial fib related to that. Now, 90% of the strokes, 90% of strokes in non-valvular AFib are related to that appendage. So if you can take a blood thinner, you're better off taking a blood thinner. Okay, so this is not an alternative. It's really for people that can't take their blood thinner. There's all kinds of new plugs coming. We looked at this one on the bottom. It's called the Amulet. It's a little bit like a pacifier. It's got a big disc on the outside, and then there's a plug on the inside. So there's all kinds of new stuff coming. Okay, so let's just summarize. So we talked about chest pain, right? I think if you've never had any heart disease and you don't know what your heart feels like when it's sick, you get chest pain, you need to see your doctor ASAP. If you particularly get it with exertion, and it goes away with exertion, it's in here, maybe it goes up to your jaw, goes up here, you need to see your doctor, okay? And get an answer, get an answer. 2, shortness of breath, frequently the cause of heart disease, or is caused by heart disease. It could be blockage, but it could be your heart's weak, your valves don't work. Pretty much anything in the heart can cause you to be short of breath, so pay attention to it. If you're on blood thinners and you can't take them, there are alternatives, non-pharmacologic alternatives to reduce your risk of having a stroke. All kinds of new stuff coming, right? Every time Eric and I, all of us think we're done, there's nothing else. They're smart, young people who come up with new, whether it's pharmaceutical or it's device-related. There's lots of new things coming. So we can do this every year because there'll be new stuff every year. Thanks for your attention. Yeah. So any questions? Yes.
Like the TAVR, do they have a procedure like that for the mitral
Okay, so there is, this is a great question. The question is, like TAVR, is there a mitral procedure? So TAVR is for transcatheter aortic valve replacements, for aortic valve that I showed you, okay? It's just TAVR short for that. And the question is, how about the mitral valve? So the mitral valve generally leaks. That's its problem. Rarely it gets narrowed. So is there something transcatheter that we can fix the mitral valve with? And there actually is. It's called a mitral clip right now. One of the ways surgeons will treat that mitral when it leaks, when they're doing open heart, is those flaps that don't come together, they'll just sew them together. And we can take a clip or two, occasionally 3 up from the leg, and clip them together. Now, that's not as good as getting surgery, though. Okay, so that's for somebody that's higher risk for surgery. Just remember, if you do need your mitral valve repaired, it doesn't have to be the big deal. It can be done with a 2 or 3 inch incision from the side. But you need a specific surgeon that specializes that. If you need mitral repaired or fixed, you need to go to a mitral open heart surgeon. That's very clear. Around the country, the average number of mitral surgeries surgeons do is only 4. Okay? This isn't bypass. You know, you need somebody special. It's like AFib ablation. Okay, so just remember that. But there are valves coming. The trouble with it, the mitral valve is right in the middle of the heart, and you're trying to drop a Coke can in the middle of the heart with these big mitral valves. So we've got a lot of work. We're in those protocols and those research kind of endeavors to look at those valves, but we're not there with that compared to a TAVR. Yes?
Is there any correlation between so-called heartburn and heart pain?
Heartburn and heart pain. So I think, and the question is there a correlation? So there is no causal relationship between the two. But heartburn and what somebody thinks is esophageal disease can masquerade as heart problems. And it actually is the heart, and it's not the heartburn. And the trouble is, a lot of people have GERD and heartburn, but they also have coronary disease, and their pains feel very similar. Okay? So part of it is if you've got heartburn, particularly if it's exertional, it's heart disease until somebody proves that you're refluxing during exercise. Does that answer the question? Yeah.
I actually have a couple of quick comments.
Yeah.
This is about 20, 25 years ago. My mother had a heart attack. Her only symptom was really severe nausea. She never had chest pain. In the ER, the doctors kept asking her, how's your pain? How's your pain? I'm not having pain.
Mm-hmm.
That just really brought home to me that, when they started looking at women possibly having different symptoms.
Yeah.
But she had a heart attack.
Yeah.
And then this is something that happened with myself. Now, I happened to be driving by St. Vincent Hospital a couple of years ago, and I was having chest pressure,
Mm-hmm.
not pain, but pressure,
Yeah.
heaviness in my shoulders and my arms, not shortness of breath, but just feeling like I had to deep breathe
Uh-huh.
in order to. So I went right into I was just driving right by, and I got very elevated blood pressure, and but I was in for over 24 hours, had all the testing, and they said, well, we can't find anything wrong with your heart. But I had,
Yep.
really big cardiac on both sides of my head.
Mm-hmm.
So, but what they finally decided was probably it was a panic or stress kind of attack.
Mm-hmm. Yeah.
And so I have to really pay attention. But they were great.
Yeah. Yeah.
They were great.
Yeah.
And they said, come back if you have any more symptoms.
Yeah.
Okay.
Well, if you get very high blood pressure, the heart has to work very hard, and so you sort of outstrip the oxygen demand, and you can get pain like that. Often people with a heart attack, they'll throw up and get nauseated. Frequently, they'll sweat with that. They'll be diaphoretic as well. But again, any symptom between here and there, if it's bad, you need to think about the heart.
Could you talk about where cholesterol fits in?
No. Are we going to talk about that? Yes. Okay.
He's not going to talk. He knows how to talk about it. I'm just not letting him talk about it. So I do want to bring up something because somebody brought it up before. So Herms, you and I work together with a lot of people with valve disease and AFib. So do you want to talk about that briefly? I mean, you know.
Yes. So frequently, you know, they run together. And it can go both ways. You know, sometimes we'll see people who their mitral valve starts to leak badly because they're in AFib a long time and the annulus to that mitral valve dilates. Or if you've got any valve disease, whether you're leaking or it's narrowed, it can put stress on the atrium and you get atrial fibrillation. I think one of the more confusing things is, hey, when can I take these new agents, right, the Eliquis, Xarelto? When I see on TV, if you have valve disease, I can't take them with my atrial fib. So there's a little subtlety to that. You can't take those agents if you have a mechanical valve. So if you've got a metal valve in you, those aren't the agents. You got to take warfarin. The other thing is if you've got mitral disease, particularly if the mitral valve is narrowed, those aren't the agents for you. But otherwise, we do TAVRs all the time in people. We replace the aortic valve with a tissue valve. You can take your Eliquis, your Xareltos, and that sort of thing.
All right. Thanks, Herms. I think we're good. Is there others? Oh, is there more questions? Oh, I'm sorry. Yeah, one more. I'm sorry. I cut you off. Yes, sir.
A number of years ago, I was a jogger. I was discovered to have a mitral valve leakage. They said we will just monitor it. We monitored it for years, a couple of years, and then I got AFib.
Yeah.
If they had taken care of that, are they taking care of that?
Be careful on this one.
No, it wouldn't have helped. You know,
There's too many lawyers in this room.
yeah. So having a little bit of leak with the mitral valve is very, very common. That structure is so complex. It's a house of cards. And I don't know how any of us have a valve that works. It is really a complex structure. So it's common that as that valve goes to close, as your heart squeezes, there's a little bit of a leak. It's of no consequence. And I don't think that's what caused your AFib. You need a big leak to cause that. So had they fixed it, no, that wouldn't have helped. Okay.
Herms, thanks so much.
Thank you.
Thanks so much. So the next speaker is Emily Rudin, one of our other partners, and you can see when you see Emily why I've given her the topic of diet and exercise along with calcium scans. Although I could have given that to Herms, but I'm the only one who can't cover that topic, even though I get asked it all the time. Emily was going to talk calcium scans, and I just sort of squeezed her arm into talking about exercise and diet. But the reason I shut down the cholesterol thing, Emily's going to cover some of that, but Kathy Bain, who is our endocrinologist and super specialty in this whole area, is going to spend a whole bunch of time on cholesterol and how to manage it. So I knew that was coming. Emily, it's all yours. So I should say one thing. I know she's going to hate when I tell her this, but before Emily was born, we decided that this morning. I asked her when she was born, and this actually symposium came out before she was born. When I was a young cardiologist, whenever that was, there was a symposium on exercise, and I was educating my young colleague about it, and the lead speaker was this 92-year-old physician from Harvard who said the following, and I know you're going to hate me for saying this. He said, I get my exercise by being the pallbearer for all my friends who exercise. So I decided never to exercise. I figured that you do. Emily, it's all yours.
Thank you so much. Thank you guys for spending your morning with us. I get to start with the easy part, which is the heart scans, and then transition into the hard part, which is the diet and exercise. I was checking the tables just to make sure there weren't any projectiles or anything out there that might get in my way. When we talk about heart disease, you have to understand that heart disease is the #1 killer of men and women. At least in this country, more people are dying from heart disease every year than people dying of all cancers and chronic lung diseases combined. And that's why it's so important. It's estimated that about every 40 seconds, a person has a heart attack in this country. How do we change that statistic? How do we make a difference there? And that's what I'm going to spend a little bit of time talking about today. As I'm going through this conversation, I want you to ask yourself this question: am I at risk for heart disease? Because I think that's a really important question to decide who we need to worry the most about. Sometimes it's easy. Sometimes you can look at somebody and say, yeah, I'm not surprised they have heart disease. But other times it's not so obvious. So how do we decide who is most at risk for heart disease? We have a certain set of risk factors that we know increase your risk for heart disease. I like to divide them into two groups. Things that we can't control, which you see sort of in this purplish color on your left. Can't change the fact that you get older every year. I can't change the fact that you may be a man or a woman. And I can't help what you may have inherited from mom and dad. But then we look at the other side, this green side. What are the things we can control? High blood pressure, smoking, diabetes, physical inactivity, obesity, and high cholesterol. Those are the risk factors that I want to go through with you today in a little bit more detail. When you look at this circle here, and if you're ticking off all the ones as yep, got that one, yep, well then that's pretty obvious. We all can probably recognize that you're high risk for heart disease, but sometimes it's not so obvious. I'm going to throw out just a couple of other risk factors that perhaps maybe people aren't quite aware of. For the women in the audience, when you had your babies, you had your first stress test. If you had any pregnancy-related complications like high blood pressure, preeclampsia, eclampsia, or preterm delivery, you kind of failed your stress test, and you might be at higher risk for heart disease. Certain autoimmune conditions are associated with earlier heart disease, and we're finding that as more and more people survive cancer, some of our cancer treatments are actually increasing people's heart disease risk later in life. And like I said, well, I didn't say this yet. When we talk about these risk factors, not all of them are equal. Some of them increase your risk even more. For example, if you're a smoker, you're 7 times more likely to have heart disease than somebody who doesn't smoke. If you have diabetes, 5 times more likely. And if you're obese, 3 times more likely to have heart disease than, say, your counterpart who is not obese. So what do we do if it's not so clear? Maybe you do exercise and you live a pretty healthy life, but maybe you have a horrific family history. That's a little bit harder to tease out. So what do we do? How can we decide if you really are low risk or perhaps you're more high risk for heart disease? And I think that's where the heart scans are most beneficial and most helpful. So let's take a moment and talk about what is a heart scan. It's a special type of CT scan through your heart. The whole test takes just a couple of minutes. It probably takes longer to walk into the building, answer our questions, and then walk back out. But what you do, you lie on the table, no IV, no contrast dye. The table slides you in the tube and then slides you right back out and takes pictures through your heart. If you decide to get a heart scan, wherever you go, you'll walk out that day with a piece of paper. And that piece of paper will give you a calcium score. We are quantifying the amount of calcium buildup in your heart arteries. Well, what does that mean? Why do we care about calcium? We know that heart disease is a progressive process. We have been able to identify the very beginnings of cholesterol and plaque buildup, starting in adolescence and even young adulthood. That's when it's actually starting. And then if it goes unchecked and uncontrolled, you end up on the other end of the spectrum here, where you see really tight clogging or even heart attack. It really doesn't do me a lot of good to see you when you're down here. Yeah, I'm going to help you not have another problem. But gosh, I'd sure love to be able to find you sooner so I can keep you from becoming part of that problem, becoming part of the statistics that I mentioned earlier in my talk. And that's where calcium comes in. The only way you get calcium in the arteries around your heart is if you had plaque or cholesterol buildup there first. Plaque deposits as sort of soft and squishy cholesterol at first, and our body, in an effort to try to control the process, hardens it, turns it into calcium that these heart scans can pick up on. You can see, well, the words are a little small, but if you see my mouse here, this is the beginning of the calcium process. So if I find that you have calcium built up in your heart arteries, I can identify you much earlier in the disease process. We can make changes and perhaps protect you from moving downstream to having an actual cardiovascular event or problem. So what is a normal calcium score? Well, normal 0. You shouldn't have any calcium in there. To put in perspective, a score of less than 100, I would consider a mild amount of calcium. Sort of 100 to 400, a medium or moderate amount of calcium. And over 400, I've got red flags and alarm bells going off. Once your score gets over 400, you're more likely to have significant blockage, more likely to fail a stress test, for example. The higher the score, the higher the risk. If you have a calcium score of 0, your chances of a cardiovascular event over the next 10 years is less than 2%. If you have a score of 100 or less, you're 2 times more likely to have an event when you compare yourself to somebody with a score of 0. And if you have a score over 1,000, you're 12 times more likely to have a problem than somebody who has a score of 0. So the higher the score, the higher the risk. So how can your heart scan be helpful to you? Well, again, I think it can really help you reclassify your risk. Are you low risk, or perhaps you were under-recognized and perhaps you are more high risk and we need to be more aggressive with you? It helps me identify a higher risk individual earlier and helps me know who I can help be healthier so that they don't become part of that statistic. For you individually, sometimes I find that these heart scans serves as a motivating factor. It can perhaps be the impetus that gets you to actually make the changes that probably should have been doing all along. We get aggressive with risk factors. Maybe you finally are ready to make those lifestyle changes that your doctors have been talking to you about. And in some cases, medical therapy may be necessary.
What kind of medical therapy? You need medicine?
Yep, and I'll come back to that in just a minute, I promise. So you go get your heart scan, you walk out with a piece of paper and it's not 0. You have calcium buildup, so what do you do now? Well, I think we go back to those risk factors. Assuming you're not having any symptoms or problems, it's an opportunity to make changes. Remember, there's things we can't control. But gosh, if you have an abnormal calcium score, I can be sure I'm going to make sure your blood pressure is well controlled, your cholesterol is well controlled. If you're smoking, I'm going to do everything I can to help you stop smoking. If you don't have diabetes, we'll try to protect you from developing it, or if you do, we'll make sure it's really well controlled. If you are physically inactive, we'll start exercising. And if you are obese, we're going to try to get you back to a healthy weight. That's how you take control over your cardiovascular destiny, if you want to call it that. That's how you prevent yourself from becoming a statistic. We control what we can control, okay? I want to take a moment and talk about 2 risk factors specifically that you guys, in a day-to-day basis, can control. The 2 things that you can do for yourself to take power back over heart disease. And that's obesity and physical inactivity. Segues nicely into the diet and exercise portion of my talk. When we talk about nutrition, I really hate the word diet. But when we talk about nutrition, there's so much out there. There are so many fad diets that have come and gone. I just put a few in there. It's all about the keto diet right now. Everybody wants to talk about that. But there's so much in there. And you have to remember that, and like I said, a diet is a diet is a diet. And I think every diet out there has its strengths and has its weaknesses. I think when you approach a nutrition plan or a diet, you have to understand what your personal goal is with that diet. If it's to lose weight, then there are diets that are amazing at weight loss, and you will lose weight. But if your focus is really improved cardiovascular health, then I want to make some suggestions there. I want you to consider this. When we talk about improving your cardiovascular health, when we talk about nutrition that's going to help your heart, there's a couple of studies. It's a really hard thing to study as diet. There are a couple of nutrition plans out there that I think offer the best chance to help you. A few years ago, they studied the Mediterranean diet, and they took pretty high-risk people and asked them to follow this diet, and they actually did better. They had fewer cardiovascular events. And so I've included the Mediterranean food pyramid here, okay? with these two suggestions here, I'm hoping I can give you an idea of how to approach your day-to-day diet and nutrition choices. Everybody has their own set of challenges when it comes to nutrition. You have your own set of health problems that might dictate what you can and cannot eat. Everybody here has their own weaknesses and indulgences. Everybody has their own day-to-day life, busy schedules that sometimes dictate what food choices we make. When we look at this Mediterranean food pyramid, I want you to look at the bottom. And I want you to see that there's a lot of green, leafy vegetables in there. We talk about nuts, beans, legumes, seeds. I want you to look at the top. That's where the meats and sweets are. I want you all to think about how you eat. And I suspect a lot of us in this room, the pyramid's probably flipped. And I think that's pretty common in our Western society. We really need to be thinking about what should go on the bottom of the pyramid, much like you see here. And if you're looking for something that actually has proof behind it, proof to actually help you do better, live longer, and have less cardiovascular disease, this is what it looks like. Now look at the picture on your right. Again, you see a pretty similar pattern. Of all the nutrition studies that are out there, the type of diet that has the best chance of reducing your cardiovascular risk is a plant-based diet. Now, I can't ask everybody to become a vegetarian. I know that's not right. But I do think we need to rethink vegetables in our diet. And I think that is probably the biggest thing we lack in terms of good nutrition for cardiovascular health. I think we need to think about creative ways to have different proteins rather than meat-based proteins, but plant-based proteins, adding that to our diet. For folks that come and see me that really have a lot of work to do in terms of diet, I ask them to try one thing. Every meal that you sit down to, I want you to look at the unhealthiest thing on your plate, take it away, and put a vegetable in there. Just start there. Don't change anything else. You guys have been living a certain way for 30, 40, 50, 60 years. You're not going to change overnight. I know that. But I think we all need to get more used to the idea of vegetables being a main part of our diet. Plant-based products is a better part of our diet to improve our cardiovascular health. Now, it's a little bit more than just diet. When we talk about obesity, weight management, physical inactivity is a huge component of that. And what I found about exercise, I have a feeling I'm telling you guys everything you've already heard and probably already know. But what I found about exercise is it's really about consistency, okay? It doesn't really matter what you do per se, but you have to commit to it on a regular basis, 5 days a week. I know that sounds like a lot, but that's really what it takes if your motivation is to improve your cardiovascular health. So what is good physical activity? Well, it's about 30 minutes a day, 5 days a week of sort of moderate intensity activity, and I'll come back to that. If you are able to exercise more vigorously, then you can get away with shorter amounts of time, 25 minutes a day, 3 days a week. I'd like to throw in there and comment on this muscle strengthening that's also recommended 2 times per week. I find that, especially as we get older, this muscle strengthening component is a really important part of helping us maintain a healthy weight. I find that as we get older, just the cardio type-based fitness programs don't do as good of a job. I really think you need to have some strength training, whether it's with weights or body weight exercises to help you maintain a healthy weight. Never mind all the other health benefits as we get older and keeping our muscles strong around bones that might be starting to weaken. The other thing that's important to know is that it's never too late to start exercising. There are so many health benefits. I promise you'll feel better. But I really think it's about commitment, and I hear it over and over again. You exercise a couple days here, a weekend there, and then you come back and see me and you're frustrated that you haven't lost any weight or you don't feel any better. We have to find a way to just make it part of our day-to-day life, like brushing your teeth. Did I get my 30 minutes of exercise today? Do you have to join a gym? No. You don't even have to get on a treadmill if that doesn't speak to you. It's really just about moving, getting out, doing something. To give you an idea of what I mean by moderate intensity, walking about a 20-mile or 20-minute per mile pace is a pretty moderate intensity activity. Water aerobics, especially if you have joint issues, is a great way to get some exercise. Bicycling at a slower pace, ballroom dancing, general gardening. Those are all fine. For more vigorous intensity activity, if you speed walk, jogging, running, swimming laps, cycling at a faster pace, about more than 10 miles per hour, aerobic dancing or heavy gardening like hoeing or raking, those types of harder gardening activities. So I hope that gives you some perspective on what I mean by moderate versus vigorous. For moderate intensity activity, you should be saying to yourself, yeah, this is kind of hard, and that's going to be moderate intensity. If you're doing it and you're saying, whew, this is really hard, then that's your vigorous intensity. So you have this abnormal calcium score. You're going to make changes on your day-to-day life, but sometimes it takes more than that. Sometimes it requires medical therapy to help control the disease process. It's one of those risk factors that we can control. It's something we can offer you to help protect you from heart disease. I'm not going to talk too much about statins because I know that talk's coming up, but I just ask that you be open to the discussion with your doctor about whether statins are appropriate for you if you have an abnormal heart scan, because I'm sure it will come up in your conversation with your doctor. So what does ideal cardiovascular health look like? Who do I not have to worry about? It's somebody with a total cholesterol less than 200, a blood pressure less than 120/80. You don't smoke. You maintain a healthy weight. Your blood sugar is less than 100 when you're fasting, and you follow a healthy diet with good physical activity like I mentioned. That's the goal. And I think I behoove you all to really make it a priority for your own health. Like I said in the very beginning, the statistics are there. And this is how we change the nature of heart disease and change that statistic in the future. So just to summarize a couple quick things. Heart scans offer a way to detect heart disease earlier. There are at least 10 different St. Vincent locations around the state where you can get a heart scan, and I've included the link for you here. You can schedule your appointment online. You might consider talking to your doctor if it makes sense for you. It's not for everybody, but it may be appropriate for you. And I would encourage you to see an abnormal heart scan as an opportunity. Allow you to, again, control what you can control. Remember that healthy habits are a way you can make a difference on a day-to-day basis. Please remember there's no magic diet. Every diet has their strength. Every diet has their weakness. I really think it's about incorporating more vegetables into your diet. Remember that exercise is about consistency, commitment, and that statins can protect from heart disease, so be open to that discussion. So I'm going to stop there. I have no doubt there will be questions, but I have some if you don't. There's one way in the back.
The cost of heart scans has come down over the years.
That's right.
It's sort of like a snapshot. As a physician, what do you recommend, to like take a second picture?
That's a great question. When should I repeat my heart scan? If your first heart scan is abnormal, I don't think there's ever a reason to repeat it. Because for me, I recognize you as someone who's high risk. I'm going to be as aggressive with you as I might be with somebody who's already had a heart attack. So I don't even care if your score doesn't change or not. It doesn't change the fact that we need to be extra careful with you and controlling your risk factors. The only time I really advocate for repeating a heart scan is perhaps if you had it done really early and your score was 0, then there might be some benefit there. Maybe I can step back and talk about maybe when the right time to get a heart scan might be. I think for most people, for most men, probably 45 is a reasonable age, 45 to 50. And for most women, around the time of menopause, so around age 50, is probably the optimal time to consider a heart scan, but only if it's going to make a difference in what you're doing. If you already have diabetes or already have heart disease, you're already treated for cholesterol, if we already know you're high risk, then it may or may not serve a very important purpose. You can talk to your doctor. There's some people that might think that's okay. But we know some people who have a really strong family history of early heart disease. For example, maybe your dad had a heart attack at age 42 and you're sitting there at 38 a little bit worried. I think then, and that would be an opportunity to consider a heart scan earlier, maybe around the age of 40. But if your score is 0 at 40, that whole calcium process that I went through, it does take time. So it may just have been that you are starting to develop more disease than perhaps the heart scan was ready to detect. And so in that case, re-imaging maybe in the next 5 years would be a reasonable time to make sure that we've really gotten it right the first time around. Yes?
Calcium supplements.
Mm-hmm. Mm-hmm. That's a great question. So there was a, yep, oh, the question was calcium supplements. Maybe you take them for osteoporosis. Will they lead to more calcium deposition in your heart arteries? We actually, there was a study that came out a year and a half ago now. People who take calcium supplements there was an association with increased calcium in the vascular system, but it wasn't a study that was looking that one caused the other, but there was a link there, a questionable link. I think the right answer is if you need it for osteoporosis, you take the recommended amount. I don't think it's a good idea to take gobs and gobs of extra calcium. Does that help? But nobody's proven that taking dietary calcium causes the calcium deposition. It's really the calcium that's happening is more because of the cholesterol that's going there. Okay? Yes?
Your target on blood pressure, 120 over
80, less than 80. Mm-hmm.
I'm 89, and mine's 136 over 70. What do I do to get it down, or am I within bounds?
You know,
Does it decrease with age?
You're right. So I gave you a general ideal cardiovascular health. You are right. Blood pressure, actually both blood pressure and sometimes cholesterol, they're moving targets depending on where you are in life and what your other health issues might be. As we get older, we kind of loosen the reins a little bit on really tight blood pressure control. It's not that you shouldn't have a blood pressure of 120 over less than 80, but we know that if I push you really hard with medicines, I'm probably more likely to cause more problems than I am to really protect you from the long-term complications of high blood pressure. I actually think your blood pressure sounds really good for where you are in life. But I think that's a discussion, individual basis to make that, to decide what kind of your goal is for blood pressure. Yes, sir?
Do you have a history of bypass surgery? Is the heart scan appropriate?
Great question. The question was if you have a history of bypass surgery, is a heart scan appropriate? And I would say no. If you already have heart disease, if you've had bypass surgery or a stent or you've had a heart attack, I don't think that heart scan serves any purpose for you. I know I've got to be extra aggressive with you, and I'm gonna throw the kitchen sink at trying to keep your heart healthy from having another problem. Yes, I'm sorry.
5 years ago, my husband had the calcium scan,
Mm-hmm.
heart scan, and his reading, and I have the paperwork from it, was 4,880.
Wow.
He eventually, is that even possible, or was that an error? He did have the angiogram, and he was okay, but
Wow.
4,887, and I've got the paperwork.
That is an anomaly, I would say. A couple of possibilities. I have to assume that it was scored correctly. It does take a technologist or even a radiologist to go through and circle all the individual calcium to come up with the score. And sometimes you can have calcium in other areas that maybe get inappropriately scored. I have to say 4,000 might be my record. I've seen a couple thousand, but I've not seen 4,000. So I'd have to look at the pictures to know if it was real. Now, again, when I went through that gradation of calcium scores, usually my patients that come in with a calcium score over 1,000 or over 2,000, they often end up with bypass surgery, actually. But actually, the way the calcium process happens, it starts in the walls, and the way it remodels is it grows outward first, and then it reaches a point where it can't grow outward anymore, and then the calcium starts to encroach in on the blood vessel itself, starts to obstruct the blood flow. So he may just be one of those rare cases where the calcium tends to grow outward and it's just a lot of it on the outside, and he hasn't had it grow inward yet.
Should he get another scan?
I don't think so. I'm hoping that his cholesterol is very tightly controlled and his risk factors are controlled. For him, it's about symptoms now. If if he's having symptoms, then needs different testing besides a heart scan.
I'm kind of arguing with my CP at the moment.
Okay.
My cholesterol's down to 120,
Mm-hmm.
and he still has me on statin. And, oh, okay.
You know, we used to wonder if we were driving cholesterol too low, if that was causing problems, but with some new medicines that have come out, we've actually found that the lower the better. There's not really a danger low anymore. So it sounds like he's being very aggressive, which I'm grateful for. He's not so grateful.
One more question over here.
My question is, based on your presentation, it seems to me that calcification is not reversible.
Correct.
Is there any kind of research trying to see whether medication can work on the decrease of calcification?
I love that question. I get it all the time. The question was, is the calcium, can you reverse the calcium? Can you make your score go down? And the answer is actually no. So that's part of the reason why once it's abnormal, I don't see any reason to repeat it. You're not going to take medicines and do all these things that I mentioned today and get your score down to a 0. Really, all the things that I mentioned today are really about stopping the disease process in its tracks, okay, halting it right there. There are some medicines, I will be honest with you, some very expensive medicines that have been shown to be associated with plaque regression on different types of scans, but not the heart scan, okay? Thank you, guys. Thank you.
So next speaker is my favorite endocrinologist. And it's very sad when we had to change offices that Kathy wasn't around the corner for me, because Kathy was my around-the-corner consult at least once a day to go through what's going on, what's the latest on this. I've asked her today to discuss this whole issue of high cholesterol, statins, interactions with diabetes. This is really her area of specialty. She's fantastic at it. I see some people here who I know go to Kathy, because they're patients of mine. I've sent it to her. And drives me crazy with this whole, you know, people sort of hit the internet and they'll come in and tell me I'm not taking my statin anymore because it causes memory loss or it causes some crazy thing. Well, you don't have to worry about memory loss if you die. So that's the truth, okay? That's good. So if, you know, you have to say, well, a little memory loss or I stay alive. So Kathy, I hope will debunk some of these weirdo things. Anyway, Kathy, it's all yours. Thank you for doing this.
Thank you very much. Well, as Eric said, I'm an endocrinologist. I'm really delighted to be here, and I'm delighted that we have such a great turnout. I'd like to mention first this sort of philosophy of life that I'd like you all to entertain, this idea that you can live long and then die short. In other words, most of us see with people around us that there's kind of this slow fade over time. And the reality is that while we're all here talking to you, it's with the idea of keeping you at that peak level of performance as well as you can be, as long as you can be well, and then maybe we'll just die in our sleep, okay? So I know that really, in real life, we get little things that happen and we see these down ratcheting. But let's try and keep it fixed because it's much harder to fix it after it's broken. Dr. Rudin has done a great job in talking about risk factors, so I'm not going to go over that again, but I am going to point something else out to you. This looks at how well we're doing as a general population in controlling risk factors. You can see that the red is not good at all. The yellow is not great, but in the ballpark, and the green is great control. So if you look to your, I guess it's, where am I? There we go, I got it. If you look at the middle column, that was the diet piece that Emily was talking about. Virtually none of us are in that ideal candidate that she was talking about. And if you look to the right where it talks about cholesterol, blood pressure, and fasting blood sugar, these aren't great either, but I want to point something out here. Just because these people are in the green doesn't mean that they genetically are perfect and doing all the right things. It means that they're under the care of someone who's helping them achieve that, okay? So just because you have these problems doesn't mean that there aren't things we can help you to do about them. What I'd like to point out is one of the risk factors, of course, is that of age. As we get older, our risk increases, and it increases significantly. The recommendations as far as cholesterol, which is the first thing I'm going to talk about, in statin therapy, ends right here at 79. Beyond that, we're kind of like totally not sure what to do. There's studies being done to look at this further, but I want you to realize that the next step that I'm talking about is for those 79 and below. And how we determine your risk and whether your cholesterol needs to be treated and to what aggressive degree it needs to be treated is based on these risk estimators. And you can pull this up. It's American Heart Association, American College of Cardiology. You can pull it up and you can put in your age and your cholesterol and your good cholesterol numbers, whether you have blood pressure problems, et cetera. And then it will give you a number up here at the top that shows what your risk is of having an event over a 10-year period. When the risk gets to 7.5% or above, then we say you need to be treated for your cholesterol. You can see that this gentleman, he seems like he should be pretty okay. I mean, his age is 55, his total cholesterol is 200, his HDL, the good cholesterol, is 40. His blood pressure, he is on medication, but it's well controlled, and yet his risk is still twice that of the normal, all healthy parameters population. The other group that we think about treating are those who've already had an event. They've had bypass surgery, they've had a stent, they've had a stroke, they've had an MI already, a heart attack already. These people are already much higher risk for having an event. Those people need to be treated with statin therapy, okay? What's intriguing is people with diabetes who've never had an event should be being treated with statin therapy. And the reason is that they are considered as a same high degree of risk of somebody who's already had a heart attack. The risk factor modification is the cornerstone of preventing another event. So what I'm speaking about, because of the issues that come up in talking to patients about statin therapy, is Eric knows that this is a hot topic. So let's talk about it. First, before I get to the statins in general, this is the healthy population. And then we have patients who have had a heart attack and what their risk is, of dying over the next whatever number of years. And then we have the patients who are diabetic who've never had an event. You can see that these are all in the same, they're in the same curve. In other words, they haven't had a heart attack, but they look like the same person who's had a heart attack. But what I really want to point out here is a patient who's a diabetic who's had a heart issue and is not on a statin. And the reason I point this out is we're going to be talking about diabetes, and I have patients who tell me I'm not going to start a statin. We dialogue about this and we talk about it, and finally I just draw this curve. And I say, which line do you want to be on? I mean, because not making a choice, or at least head in the sand, is actually making a choice. So you need to know that you might be making a choice that is a really downward spiral. So I just want to reiterate that because sometimes we are trusting our doctors. The overwhelming evidence with statin is that lower LDL is better. The first statin was introduced in 1987, and so they've been here for over 30 years. They've been extensively studied. Hundreds of thousands of patients have been studied, and they're very potent at getting the LDL cholesterol low. And the LDL is the bad cholesterol. Clear benefit of using even the more potent, the higher doses in patients who've already had an event who are at high risk. And someone was asking about, somebody was asking about amount of cholesterol. So when you look at this, this is just taking 170,000 patients that were studied and sort of putting this data together and seeing, is there a point at which we've done enough, if you will. So these patients are about 130 here, and you can see that their risk of vascular disease drops by getting them to about 100, and you've heard that as a goal for LDL cholesterol. You go down to about 70, it's improved even further. And we don't know exactly where the benefit, where we don't derive any more benefit, but you can see that lower is better across the board, okay? Sensationalism. this is what you're up against too, because you pick up the newspaper or you pull up your tablet or whatever, and you see that statins cause something, whatever it is. It's something horrific. It's some kind of cancer, and you don't know enough about the cancer, but it's something, you know, like that really gets your attention. And they say it doubles your risk. Please listen to this for 1 minute. You don't know whether that risk was 1 in 10 and now it's 2 in 10, or whether it was 1 in a million and now it's 2 in a million. It's scary, and I don't blame you for being scared. You think, I'm taking a medication that could be doing a negative thing to me. But the reality is what you need to do is you need to pick up the phone and you need to call the office. And you just say, did you see this study? And does this apply to me? And am I at risk? Because unfortunately what commonly happens is people actually just stop their medication. And we don't know that until they get back into the office, okay? So trust your provider. Ask them about whether or not this is something I need to be concerned about. So in this particular group of patients, I just want to go through what people tend to ask and what their concerns tend to be, and I may have missed something, so we'll have some times for questions at the end. First one is liver tests. Whether or not the liver is going to be damaged, okay? So we follow the liver tests, especially early on, to make sure there's no evidence of any liver problems. The reality of significant damage is exceedingly low. They may flutter up a little bit. The liver function test may flutter up a little bit. We don't get excited until they're 3 times normal, so just a little bit of elevation is not worrisome to us, but it may be dose dependent. It may be the specific type of statin we're using, so we can change things. The one that's probably the most common is muscle achiness. This was very intriguing to me because 15% of patients who were on the statin had muscle achiness, and 19% who weren't on the statin had muscle achiness. So what does this show us? It shows us that muscle achiness is very common, especially as we get older. I think it's intriguing because about 30% of the people in the placebo group who were not getting a statin stopped their medication because they were having the symptom. With patients, what I will ask them to do is I will have them stop it for 2 weeks. If it goes away, then we say, okay, let's retry the medication and see if it's related. If it doesn't go away, it doesn't seem like it's related at all, so they discontinue medication. But I don't want to undermine the reality that people have achiness, and some people have pretty profound achiness, and some do on one statin, but they won't on another. So we can work with that, okay? There is a very small risk, but a risk of more severe muscle pain, and that's where sometimes we'll be checking muscle enzymes and that kind of thing. What I like patients to do is call me again instead of just stopping the medication, because the other thing I want to know is I usually want to see what the cholesterol was on the medication, if we were even doing what we wanted it to do before they stopped the medicine, okay? The other thing you've heard about probably is type 2 diabetes. The FDA has made a statement and put it in, you know, the information that we get about the statins, that there is a small increase in risk of diabetes. It's incredibly important to recognize that this generally happens in people who are at higher risk of diabetes, or a patient who's already diabetic, and we see a slight increase in blood sugars. We're going to talk a little bit about how to address that and maybe even help prevent diabetes to begin with. Because of that very high risk, remember I told you about diabetics and their need for aggressive therapy, we still give them statins. It's exceedingly important for them to be on them. Neurologic, we had this question, you know, does it make a change in your mental status? Well, there have been reported cases of people having some memory loss. It's reversible once the medication is stopped. It's very limited evidence as to it being a cause and effect relationship. But here's what we need to think about here. We have A is your healthy 25-year-old brain, and B is your 75-year-old brain. And this is normal. This is normal aging. So if you're having some memory issues, that's common, okay? It doesn't mean you're losing it. But what's more concerning is these tiny little strokes that happen. Now, it may be, like Dr. Hermiller said, that you have little clots because you have AFib, but more commonly is these are little tiny strokes that happen. And if you have more of those, you start to really interrupt the brain's ability to think. It's progressive. I'm not showing this to scare you as much as to think about what are the things that help prevent this. The same things that help the heart are the things that help the brain. So keeping your blood pressure under good control, keeping your cholesterol low, the exercise, all of those things are the very same things we do to protect our brain. Okay? So what if you struggle with statins? Well, we may decrease the dose. We may scrap that one altogether and try a different statin. What I commonly will do is I'll start low and go slow, and patients who've been on a dozen different types of options, and what I'll do is we'll say we're going to take one pill 1 day a week. And after 2 weeks, you're doing okay, we're going to go to one pill 2 days a week. And then 2 weeks later, if you're doing okay, we're going to go to one pill Monday, Wednesday, Friday. And then we're going to check some cholesterol, and we're going to see where we are. Because our goal is going to be this drop of 50% in your LDL, independent of where it started. If your level was 80 to begin with, we probably want it to get to 40. And that seems like, oh my gosh, 80 is already good. Well, not as good as 40 if you have vascular disease or if your risk is high. Once we start getting you on a statin and getting the maximum dose we can there, if we're still not at goal, we may add a second agent. So if you have an agent like a statin that works on decreasing the production of cholesterol, and then you add another agent that decreases in your absorption of cholesterol, you can see a profound benefit by using small doses of 2 agents instead of having side effects on higher doses of 1 agent. And then lastly, PCSK9 inhibitors. This is the biggest, newest kid on the block. These are injectable medications. They're used every 2 weeks, and they profoundly drop LDL into single digits. So part of the question is how low can we go? Is there a point at which we're going too low? Well, at least in the studies that have been done on these, it doesn't appear that there's a change in mentation, the ability to think on these very low. Now, do we need somebody with an LDL of 9? Probably not. But so we can back off on, because we add these to people who are high risk, they have progressive disease, or they can't take statins. We add it to whatever they're already on. Sometimes we can back off on some of the other medications. So let's talk about diabetes. How do you know if you have diabetes? Well, you may have heard of something called an A1C. That is basically, it's called a hemoglobin A1C. Hemoglobin, as it circulates through the body, little bits of sugar get attached to it. The red blood cell, which contains hemoglobin, lasts for 4 months. Half are new, half are old. So that tells us a 2-month period of blood sugars, okay? So what your average blood sugar has been for 2 months. Less than 5.6 is considered normal. 5.7 to 6.4 is impaired, some degree of impaired glucose tolerance. And then above that, 6.5 and above is frank diabetes. Or with a fasting blood sugar less than 100 is normal. 100 to 125 is some degree of impairment. And then above 125, 126 and above is diabetes. I want to spend a little bit of time on this. It looks a little bit confusing, but trust me, you're going to get this in a minute. This is a trial that was done to see if we can prevent diabetes. Okay, so they took people who were pre-diabetic. They were in that gray range that I talked about, some degree of impaired blood sugar abnormality, and they randomized them to 3 different options. One is they just live their life. Okay, that's this right here. The next one was they were on metformin, which is a medication that's traditionally used for diabetics. They were placed on metformin. And the third group was placed on lifestyle modification. The people who were on metformin had a drop of 31% in their risk of developing diabetes. The people who made these lifestyle modifications had a drop of almost 60%, and people above the age of 60 had a drop of 70%. Profound benefit. Tells us it's never too late. Okay, so that's all good news. So what was the lifestyle intervention? And this is key, and I want you to kind of remember these very important things. First of all, we're following a healthy, low-fat, low-calorie diet with the goal of losing 7% of your body fat, of your body weight. So if you weigh 200 pounds, the goal was to lose at least 14 pounds and to maintain it. That I think is exceedingly important because, like, if you read, like, you know, Ladies' Home Journal or something, women say how much weight do they want to lose. It's like 35% of their body weight. You know, I mean, it's like these very high numbers that we're starting with a goal that, let's start with realistic expectations, okay? But this is very doable. The physical activity part is just as Dr. Rudin mentioned, we're 150 minutes of moderate intensity activity on a weekly basis. 30 minutes, 5 days a week. Sound familiar? 7% body weight. These are the people who drop their risk almost 60% and more if they were above the age of 60. And this is called the Diabetes Prevention Program, and it's being done at a YMCA. There's being done at YMCAs around here. So if you want to, take part in this, call, or you can do it at home. I would say one thing about the exercise. I'll oftentimes, because people have trouble fitting it in, I'll tell patients when you get out of the car, go take a walk around your building before you go in. Do it again at noon, and do it again before you get back in the car. You can incorporate it through the day. There is good information about 10-minute intervals are fine. You can do it that way. And it also gives you sort of the freedom of realizing, okay, when can I fit an hour at the gym in? Incorporate it into your day. There are medications that are diabetic medications that actually have some degree of heart protective effect. And I think if you're diabetic, you definitely want to hear about this. Certainly metformin has been around 40 years now, I think, but it has been shown to have a mild decrease in the risk of vascular disease. Sodium glucose cotransporter 2, we call them SGLT2 inhibitors. They work by decreasing the amount of sugar that is reabsorbed by the kidneys. So the kidneys filter the sugar and then they take a lot more of it back into the system. These allow it to go out into the urine, and these have been shown to have some pretty impressive effects in decreasing risk of a second event and in decreasing progression in kidney disease in diabetics. And then the glucose-like peptide inhibitors, GLP agonists, those are medications that are injectables. They're given once a week. All of these also have a weight positive effect. In other words, people tend to lose weight. They're not weight loss medications, and it's not a profound weight loss, but there is weight loss associated with these. So let's not lose sight of our goal. When you have 400 other things you'd rather do besides get on the treadmill, think about this. Think about the goal that's maybe 20 years down the road, 50 years down the road, because we can get too distracted by the dailies. All right, does anyone have questions for me? Yeah, yes.
My question is regarding cholesterol. I remember 10 years ago, I was looking at research with Merck. They're talking about, they say that cholesterol is less important. Now it's looking at particle size. So can you elaborate?
So that's a great question. It has to do with particle size. Sometimes you can get more sophisticated testing that shows you how big your LDL cholesterol is, how many HDL, it gives you a lot of data. Particle size, you don't have to have that kind of specialized testing to know what you're dealing with. You can get it, and there's certainly times where I do get it, but the reality is that if your triglycerides are high, we already know that LDL particle is small. Why is that important? Well, the LDL particle, think of it as, you've seen these kind of more simplified schematic. Think of it as being smaller so it can get into the blood vessel a little easier. That's a very simplistic thought. But the reality is that that's kind of what we're thinking, is that the small LDL particle is more aggressive and can get in and cause more damage. What are the ways that we change that particle size? Well, diet and exercise, because the most common reason why we have that problem is obesity, not a healthy weight. I don't like to use the word overweight and obesity because people take offense to that. It's really just a clinical term. It's not intended to be offensive, but let's just say unhealthy weight. If you have an unhealthy weight, you're going to have more particles and you're going to have a lower particle size. Yes?
Wait, we have some microphones, believe it or not. So if you raise your hand, we'll get a microphone to you. Suzanne, can we, just so everybody can hear you? Okay. We actually had them sitting there dormant. They weren't doing a lot of good on the back table. Suzanne, right here. Thank you.
What is your opinion on the AHA guidelines for LDL and HDL?
Well, you know, the newer guidelines were a little bit controversial. The question became, do we just lower the LDL 50%? As opposed to the prior guidelines that had specific numbers. We got to get to 100, we got to get to 70, et cetera. Remember, lower is better. So our tendency is to, especially if somebody has vascular disease, pick a bigger gun to really lower that cholesterol significantly. There are some people who have significant elevation of LDL, and up until these very new options that we've had, it's been exceedingly hard to get their levels below 70. So there was some reassurance that came from the fact that the studies show that it's the percentage lowering of cholesterol. Good, we got it down from 200 to 100. We've achieved a major goal, okay? So I think we're using both, honestly. You know, certainly for my diabetics, I want to see them below 70, and even if it's more than a 50% drop that we've accomplished. Yes?
I'm a type 2 diabetic, and my last 3 consecutive A1Cs have been 5.3, 5.4, and my HDL was 47. And my primary care physician says that's too low, and I always thought the lower the better.
Yeah, so it's again a little case specific. If you are on medications that do not cause hypoglycemia, and metformin's a great example of that, but there are other ones, and you're able to get your cholesterol or your A1C into normal range, fantastic. That's wonderful. I would not have lowered it, honestly. But if you're on medications that can cause hypoglycemia and you have a normal A1C, then you're probably getting low pretty regularly. So again, it depends on the situation, but to be on medication like metformin that doesn't cause you to have low blood sugars, it simply normalizes your metabolic milieu. That's great.
Oh, sorry. Do I go? Or
yes, go.
There was a picture on the screen of a brain that had tiny little white dots indicating mini strokes.
Right.
Now, how does a person know that they've had a mini stroke?
Well, you may or may not know that you've had a mini stroke because you may or may not have had symptoms with that. Sometimes it's found unexpectedly when somebody gets a CAT scan for another reason. We don't routinely do CAT scans to look for that, but if you've had, I don't want to see a change in thinking because we've all had a change in thinking as we've gotten older, but if you've had a significant event where you think, whoa, something's different, clearly you need to talk to your doctor about that.
Okay, thank you.
Who's somebody over here? No?
There's somebody over there.
I'm sorry, where? This gentleman is.
Question about metformin. My physician has got me taking 250 milligrams an hour and a half before dinner. Hitting that hour and a half before dinner is tricky sometimes, actually most times.
Sure.
But is that a regime that you would recommend? I mean, I'm not trying to second guess him, but...
Right. Well, the question, of course, is metformin dosing. Metformin dosing is dependent in part on kidney function. It's also in part on what your blood sugars are doing. I think the hour-and-a-half timing is less important. So if you get it in a half hour ahead of time, it's fine, okay? It's a little bit of an unusual regimen, but without knowing the whole story, it's a little hard to make any more comment on it.
Can I ask one more question about metformin?
Sure. Do I have time? Yes.
Is there any indication that it causes or can contribute to leg cramps at night?
Leg cramps are, well, cramps in general are very elusive. You look for all kinds of reasons for them. I would think on that low of a dose of metformin, that would be unusual. But if you have kidney functions and abnormalities, that's when we see some acidosis develop on metformin. So it's conceivable there's some slight, relationship. But we do the workup, we check the electrolytes, we do all these things, and it's, at least in my experience, very difficult to come up with a reason for leg cramps, honestly.
Did someone say earlier or ask earlier if there was a prevalence or a connection between the number of mini strokes a person might have and dementia?
Oh, well, yes, there's no question that there's a correlation. It also depends on like where they are. Obviously, some are going to interrupt mental processes more. But the other thing is interesting about it, even in Alzheimer's patients, there are people who, when they have autopsies, the brain is clearly much more affected, about the same as another person with a lot of symptoms. So we're always trying to, the reason that we would do things like trying new things as far as exercise or that kind of thing. If you're always developing new routes in the brain, then you're less likely to have them all interrupted, okay? Is that it?
Thank you very much. Well, thank you, Kathy. In a large practice like ours, we were sort of in a catbird seat because frequently patients will ask something that, you're not necessarily up on. There's no way anyone can be up on everything. I'll text Herms, or I'll text Emily or Kathy and say, hey, what's the latest scoop? Someone just asked me this. So we have that advantage in a large practice. But I think the key that you heard, and that's why I really wanted Kathy's message to get out there, I am forever battling PCPs. I just got to tell you, I tell Kathy that all the time. I want to start a statin because I'm worried about something. The primary care doc says, no, I put them into the formula and they don't need a statin. So then I tell them, go get a calcium scan. I said, fine, we'll have a tiebreaker. And the calcium scan comes back 40. And I said, there's no more discussion. You're going to be on a statin. I mean, you got your whole life ahead of you. And these silent cerebral infarcts that they're called, that she was showing you, are very worrisome. And they're well known in our area because an atrial fib, if you're not appropriately anticoagulated, there are more of them. And interestingly, there are some early data suggesting they could be actually encouraged by warfarin versus the newer agents. There's a whole theory of microbleeds. Now, whether that's true or not, I don't know. But it's one of the reasons why most electrophysiologists will lean towards these newer agents. So these are all the things you need to discuss with your doctors. Now, the next topic, it's kind of ironic because, first of all, I love Scott. He's helped me for like 30 years. He's always the guy getting me out of trouble. He's a clinical pharmacist, a pharmacologist. And I've asked him to talk about supplements because I find the following ironic. Patients will be in your face about a $25 copay, yet they'll pay $100 a month for junk, okay? Just pure junk.
That's the editorial.
That's my editorial. So having said that, I've asked Scott to talk about junk. No, I'm kidding. I've asked him to talk about all these supplements that you all think are keeping you healthy for life, and you'll come in and you'll tell Dr. Hermiller, well, I know I had a heart attack, but I'm on the latest supplement. It's great. I get it from Canada or maybe Puerto Rico or wherever it may flow into, and I know I'm going to be okay for the rest of my life. And where'd you get your information? Well, the internet. So I've asked, yeah, that's right. So I've asked Scott, who's my go-to guy, to just walk you through some of these supplements. I've already kind of biased my opinions. I'm sorry about that, Scott.
I was on the fence about that.
Scott, it's all yours. Take over.
Good morning. So I have 20 minutes to talk about natural products. So wish me luck. I know how you feel, and I know how the medical community feels. And I'm a trained scientist. I was trained in the art of medicine. And I kind of have the same feelings in some regard. But the more I speak on this, and you and I spoke on this last year in Dallas at a very similar conference where we were speaking to patients. One of the subjects that they wanted the most was natural products. And we had an hour talk on this, and I mean, after the talk, there were lines of people that had all these questions, and almost everybody in the audience is on these things. I mean, this is almost the biggest secret in the room, that who's not on one. And what the issue is that it's not the fact that they're on them, the fact that we don't know you're on them, and the fact that you're not telling us you're on them. And then we have to figure out what the problems are, because you're on a product that probably interacts with the drug that you're on that has caused a complication that we don't know. So I'll go through these products, and I'm going to pick probably the top 10 and go through them, and I'm going to make some emphasis. You're not going to leave here with me telling you everything that goes on with these supplements from aisle 1 through 10 at Walmart, because there's just too many. But I think I picked out the top 4, 5, 6, 7, and I'll go through those and see if we can't get a theme with this. Now, I'm going to qualify this statement because I'm a pharmacist, and I subscribe to the way the FDA does approval of drugs, and they do it based on science and efficacy and safety. None of these products we're talking about today has been vetted by the FDA. There is no proof that these drugs, these supplements work. There's no proof that they're safe, effective. All they tell you is that the bottle will say that it has this in it and that it's labeled appropriately. So big downfall between what we call legend drugs, prescribed drugs, versus what you buy over the counter. I'm going to make statements about these drugs are used for this, that, or the other, these supplements. I'm not saying that that's what they are good for. I'm just telling you that's what they're intended for. So please don't subscribe to the fact that when I say something about that, I'm not advocating for this at all. You alluded to it. Dr. Google. We all use it. I use it. In fact, when I did my presentation, I did it. And I did it because I wanted to see what you're looking at. And for the most part, it'll get you to the 50-yard line. It'll get you to what you need to know. It's the second half of that you're missing. It's the part that it's not telling you. It's the part that you can't vet. So what we're looking for is something to show us that these products do the things that they say they're going to do, and are they going to hurt me. So the other half of Google is it's got horns, and you've got to recognize where the horns come out at. Let's start with the elephant in the room, CBD. I don't know, I'm not going to take a poll, but I would imagine somebody in this room is on CBD. And just based on the sales from 2017 to 2019, it's becoming a percentage of the GDP. I mean, it's really, I'm serious. It's significantly becoming part of our economy. And it's the fastest growing business. And so half of our drive isn't the fact that people want it, the half of it is it's driven for financial benefit because there's so many people getting into the business. I'll give you the facts on CBD and I'll let you draw your own conclusions. This is one of the few things where the government has reacted and reacted quickly. And what they've done is we have to implement some laws because CBD is not pot. And we've got to make that clear. So we have to create some laws to make the distinction, and they did. So in 2018, Indiana passed a law that says that it is legal to grow, sell, process hemp. And in 2018, because of what the Congress did in 2018 by passing the Farm Bill, which said that hemp is a legal plant, it is no longer categorized as cannabis like pot, it now can be grown into the regular market. That opens up the whole door of bringing this to market, and it's gone quick. So what is cannabis? When you think of THC, you think of pot. THC and hemp come from cannabis, but there's two forms of it. And one is THC and one is hemp, or CBD. Anything that has less than 0.3% of THC is considered CBD. Anything over 0.3 is THC, is pot. But those plants really kind of resemble each other just solely based on the fact of how much CBD or pot is in it. So what does it do? I'm over 50, I'll put it that way. And in my lifetime, pot's been a part of the world. It's there. Only in the last 20 years has science started to look at what is it doing. And the one thing they discovered is there's a physiological system called endocannabinoid system. And this physiological system resembles other physiological systems that generate and cause physiological effects. They found these receptors in the brain and the immune system that they didn't know what they did. And if they have receptors, they must have some physiological response to stimulate these receptors. So for the next 20 years, they were looking for the source. They found the source was cannabidiol, CBD1, CBD2 receptors. They don't know what they did, but they did know that those two go together and they stimulate a response. They even have determined that there's a deficiency called endocannabinoid deficiency syndrome, that when it's low, and they can measure it, it will tell you that your CBD is not functioning. And CBD is a natural substance. We have it in our bodies. It's not like it's endogenous. We have it. We just don't have it in the right amounts. So when you take CBD, the theory is that you're replenishing or supplementing what is supposedly already a natural substance. When I said Google gave you the facts, it didn't give you all the facts. It didn't tell you that, hey, if you're on other drugs and you're on this product, you have got to be aware of the complications with this. And I retired in April, May, I think it was. I spent a good 6 months today. My last phone calls, I was getting in my car in the parking garage, came from your partner, CBD. The last one, CBD. Of all the things that I contributed to St. Vincent's, that's my going away party. And what I wanted to know was, this patient's on all these antiarrhythmic drugs, he takes CBD, blah, 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 what do we do? We went through this 20-minute dissertation of not saying whether it's good, better, and different. It was finding a reason why he shouldn't be on it. Not that he should be, because there are so many people on this product. Now we're trying to find a reason why they shouldn't be on it. And the consensus was, if it doesn't have drug interactions, it's not harming anything, it's difficult to fight that fight. So choose not to fight that fight, is what the consensus was. In your practice, physician's practice, everybody, this is really something we deal with every day. It is becoming so prevalent. But anybody that takes this product, please be transparent with your prescribers. We have to know this, because the drug interactions that I'm showing you here, I don't know what I hit. Oh. I forget how to use a computer. So I have implored you, so if you're on these products, please tell us. Most of the ones that I'm listing today have interactions with warfarin, so I'll repeat myself 20 times. But we have strong concerns with patients that are on these supplements and are taking blood thinners because they generally enhance the effect of the blood thinner. All the things we've heard about bleeding risks just got compounded. If you've ever had a drug and they said, well, you know, you can't take grapefruit with this drug. Does that sound familiar to anybody? Okay. The reason is because your body has enzymes in the liver that metabolize drugs. And what it does, it converts them from one type of a structure to a different structure, and then you can excrete them. Those enzymes can be altered by drugs. So drug A, you're on drug A, we give you drug B, and all of a sudden they're competing for the same way to get out of the body, and one of them loses. Grapefruit plays in that just like drugs do. So whenever we see somebody that says, I can't take grapefruit with my drug, slash CBD. And that's a whole lot of drugs that you shouldn't be on or shouldn't be taking this with if you're on those drugs. It's easier to say what you shouldn't take than versus what you should. I've got 5 buyer beware points, and I'm not going to go through these in detail, but you have to know when you're buying this product what you're buying. Recognize that CBD is new to us. It's old in Asia and Europe. They've been doing it forever. Most of the CBD that we buy in the US comes from Asia or Europe. 3 states, Kentucky, Oregon, and Colorado, have really shored up the market for CBD in our country because they grow all the hemp. So one thing good about it is when you have conglomerates like that, they grow that much, they generally regulate themselves well. So when you find a product that's from one of those areas, that's probably a bonus. Know how much THC is in it. It's labeled 0.3. Don't assume that's how much is in it. And I'll show you why. Where was it grown? It'll tell you where it's grown. Was it laboratory tested? Believe it or not, they're testing this stuff by self-protecting themselves, and the manufacturers are laboratory testing their assays to see what's in it and to show this. That's a reliable company, and you can see it on the label. Indiana just passed a law that says in Indiana, you can look on the label, and it will have what's called a QR on this label, and it will tell you. If you put your phone to it and access that QR label, you can pull up the lab result that that manufacturer did, and will show you what's in this product. That is what the intent of having a reliable product on the market is. And in Indiana, we're the first to pass that law. Make sure that the product is made with full spectrum CBD oil. How they get the stuff from the plant to the bottle is the process, and the CBD oil is a little bit more refined way of doing it. So if you have interest, that is probably more important. What I mentioned earlier about labeling, I'm not going to go into this detail, but they looked at 21 products and put them through a laboratory and found out that 60, 70% of them were so off in their labeling that it wasn't even funny. There is, I'm not sure if you can see this because it's a very difficult slide, but one of these columns, this third column here, is 90%, 100%, 74%. That's how much off the labeling is from what it says on the bottle out of 21 samples. Most of them are off by 50%, not even close. And probably it's over THC than it is under CBD. It's over THC, too much THC. Same thing in Finland. They bought 75 products, measured them. 17% were accurate. 60% were over-labeled for how much THC is in the product. That's not what you want. Actually, too much THC, whether you like it or not, is not going to get the benefits you're looking for. Okay, let's switch to Q10. I've been in this since the 80s, and Q10 was really strong when I came into the profession. It's still surviving after all this time. It's been studied extensively in heart disease. In fact, one of the partners, your partner, was one of the early investigators for CoQ10 in heart disease. It's called ubiquinone. That's what we call it. We call it ubiquinone because it's ubiquitous. It's in every cell in the body. So this is a natural supplement to us. I don't remember computers doing this. What is it? Yeah, it's growing quick. What it does is it maintains, we'll just say, for lack of a better word, homeostasis. The body has a balance system, if you will, and it likes to stay in balance. And when something's out of balance, it tries to fix itself. And in fixing itself, it is out of balance. So moving things back into balance, if you will, whether it's energy, whether it's hormones or endocrine or whatever, that balance is probably what this is really trying to do, is shift energy from one part, i.e. food, into the cells where they can be absorbed and do whatever they do. Q10 is what I call the shuttle. Drives it into the cell. Doesn't have enough Q10, it's just not going to get in there. Several things cause alteration. One is age, like a lot of things. Dr. Bain showed the changes in age and decline of function. Also, it showed that maybe if you have some diseases, you have a decline in Q10 levels. Also, statins are known to cause a decrease in Q10 levels. And whether that's relevant to the leg cramper issue is almost a whole talk in itself. But some people feel that CoQ10 supplements helps that issue. I don't think that's ever been proven. Drug interactions with these products. Again, this is imperative that we know that you're on this because of the drug interactions. And the ones that we care about are usually the ones that ideally are heart patients because the drugs that we're using, almost all of them interact with Q10 to a negative effect. So if you are on them, just let us know. We're not always going to say no. I'm not sure of that. I don't think we're always going to say no. But we are going to tell you how to navigate it if it's non-negotiable. We'll put it that way. These are the next 10 or so, and I'm not going to go through all these, but I put all these in the same category. I call them my natural anticoagulants because every one of these cause your blood to thin, and they cause bleeding. And by themselves, probably not traumatic unless you're prone to something. Put it in the right combination with certain drugs, and it's a significant problem. And if we're talking about blood thinners, and you add that to these, and it is significant. Let's start out with turmeric. I got to tell you, I'm surprised. This guy's like number 2 or 3 on the list. And I don't know how many people consider turmeric their primary herb, but honestly, year after year after year, it's in the top 5 for a lot of reasons. So turmeric is what is in curry. It's obviously a food source. It's also a supplement. Its claim to fame is 3 things. It's analgesic, and it's actually considered not a bad analgesic if you take sufficient amount of it, you know, on the par of acetaminophen, ibuprofen. It's not a codeine, but it is pretty effective if you take it as an analgesic. It's an antioxidant, and right now antioxidants are the rave. When we have illnesses, our body kind of creates, I'll say, garbage, for lack of a better term, and that garbage has to be disposed of. That garbage, i.e. is free radicals, and how we get rid of those is any host of ways, but one of them is using antioxidants to try to dispose of them. And this is considered a pretty potent antioxidant as antioxidants go. So keep in mind, though, this is available in food. It's also available in supplement. For people that have a curry interest and they have a lot of curry in their diet, they're more prone to have the adverse effects of this product than they are just using the supplements, because the food source is probably much stronger than what's in the bottle. The biggest concern is the active ingredient in this drug is coumarin, and it sounds awful close to Coumadin. And coumarin is a precursor to Coumadin. So yes, it is. They're sister cousins of different mothers or whatever it is, but they are related. So the bleeding risk with this is significant. And honestly, this product, in fairness, I've never seen it really, it doesn't get absorbed. You can almost take the whole bottle, it just doesn't get absorbed. What patients do is they take it with either black pepper, of all things, black pepper, and in black pepper is a substance called piperine, P-I-P-E-R-I-N-E. Piperine stops the excretion of this and many products from being excreted, and you retain them longer. And you increase the absorption of this product from 3% by thousands of percent, 1,000%, 2,000%. It's huge. And so the catch is how much piperine is too much. And where the data has shown this product to work, is when it's combined with something like piperine or black pepper. Ginger root, again, buy it in the shelf at the market, buy it in a supplement store. It's the same family as turmeric, very similar cousins. It's an antiplatelet product, and it's a pretty potent antiplatelet. So people that take aspirin, nonsteroidals, the bleeding risk with this is pretty significant. It has really 3 good effects. It's very, very profound in treating nausea. It's been studied extensively in Asia as an anti-tumor product for cancer. And in fact, in some of the Asian markets, they may actually use ginger root as a true product along with chemotherapy as a treatment for some of the cancers. And probably the best thing that they found is that this may have some kidney protective effects against chemotherapeutic agents. Because a lot of chemo agents hurt kidneys. And they're finding that this or something similar to this can protect the kidneys against those drugs from causing kidney damage. My first slide, I said, I'm only saying the facts. I'm not advocating because I don't think the science is there yet. But it's interesting how Asia has adopted this particular product of all into a whole arm of oncology. Ginkgo, another age-old product. It happens to come from one of the oldest trees on Earth, the ginkgo tree. It remains to be the 4th most sold product on the market for 30 years. I mean, this product hasn't gone away. It has antiplatelet, anti-inflammatory properties, but its biggest thing is that it's used for dementia, to help patients with memory loss, for cognitive function, et cetera. So it remains to be a very, very highly sold product. Also a very strong antiplatelet agent. A couple more and I'll wrap up. Cinnamon. Who would think cinnamon would be in this category? Sounds like a food group. But in reality, cinnamon has a lot of benefit that's highly more so in Asia, but it's been used quite extensively over there in especially in India as well. It has antioxidant effects, it's anti-inflammatory effects, but keep in mind there are two cinnamons, the kind that we have access to and probably the kind that we don't. And the kind that we don't is really the kind that we would like to have. This first kind, I think is called cassia cinnamon, is what we see in the store. It's what we're used to the taste. It's what's in our cinnamon lattes. It has some, quote unquote, some benefit, but it's very, very small. It's really not where the benefit comes from. And more so, it has this, i.e. coumarin effect, as many of the others do. And it is one of the substrates of the product, is coumarin. If you want the benefits of cinnamon, you've got to use this one called Ceylon, C-E-Y-L-O-N. You can get it in supplement stores. It's not the same cinnamon that's available in grocery stores. It's taken in pill form because it tastes extremely bad. Apparently, it's not even palatable. But recognize that there is a difference between cinnamon. It's not all cinnamon. One more, L-carnitine. Are you guys familiar with L-carnitine? This has been around forever. Some people measure carnitine levels in the blood. It's a practice. And carnitine is a natural substance. We use it for a host of reasons. There's a product called SAM, S-A-M-E. And SAM-E is what is used in our body to convert one thing to another. And methionine and lysine are the two components of SAM-E. And those components are really intended to help more of the same of what we talked about before, is physiologically harmony or homeostasis. There's a lot of, if there's ever data for these kind of products, it may come out in carnitine for treating heart disease, of all things. And there's concerns that whether carnitine deficiency leads to some type of a heart failure type of phenomena. I don't think it's supported in our country, but a lot of countries have placed all their emphasis in whether carnitine has benefit for patients with left ventricular dysfunction or heart failure. Interesting, it's stored in the muscle. Almost all of it's in the heart, which is one of the reasons why I studied there. Also of interest is if you take L-carnitine, it almost needs to be taken with Q10. And as I mentioned before, Q10 is like a shuttle bus of moving product from one part of the body to the other. In the absence of having that way to get into the cell, it doesn't get in. So carnitine by itself doesn't really have a way of moving into cells to work. Q10 is the shuttle that really helps with that. So you almost need to take these in combination. Again, I'll echo the same component. Warfarin is a drug interaction, significant drug interaction. This is also thyroid medications of becoming hypothyroid with this. Now, this was not on my radar at all, but I did get asked to speak about this in Dallas. And it was an AFib conference, and apparently this is a substance that's well studied in patients with atrial fib. And in Asia, it's interesting, it's the first herbal that's been categorized as a quote-unquote drug in the Chinese registry of drugs. They placed a lot of emphasis on this. And when you look at the science behind this, what it does is it does affect the electrical potential in the atrium. It does have an affinity for the electrical system in the atrium, i.e. AFib and PVCs. What's done in China and Asia is that they combine this with amiodarone and one of the other antiarrhythmics to lower the dose of amiodarone. If you keep reading further down the lines, what you also find is they have a high rate of quote-unquote proarrhythmia, where you have too much of an effect of a drug. It works, but now you've got the effects have become adverse effects. So it truly does have a potential, especially when combined with other antiarrhythmics. The drug interactions are very similar to the other. How you take this, you take it in granules and you mix it with hot water, i.e. tea or something, and drink it. And it's surprisingly new to me. The audience that I was presenting to, it was age old. They were so familiar with it, they knew it well. So it's amazing how many people were really turned on to this. Last is essential oils. The only reason I say this is because I know a lot of hospitals, a lot of spas use these oils for aromatherapy. Recognize one thing, when you're using these kind of oils in mass, they definitely have the effect of blood thinning properties. So spas, places where they use these at large. We use them postpartum in our moms as a spa-like effect. And they do use them in mass. And they actually, I didn't know it, they come from the pharmacy. I've been there how many years, I never saw them. But apparently we provide them. But they have a high risk of potential bleeding as well. So people that are on blood thinners just need to be aware of this. I started out with my Google slide. I'm going to go back to this slide. If you need to reference what it is you want to use, Google's great. I can't argue that. But if you really want to get deeper into what these things do, approach it the way the Europeans approach it. And Germany has cornered it. They have what's called the German Commission E monographs. And they take these products through a vetting process like we do with the FDA for our drugs, and they put them in as monographs. And in there they talk about efficacy, safety, how they're done, adverse effects, et cetera. They treat them a little bit more formally than we do, and they use these products. So you really, if you make it into the monograph book itself, it's probably one of the more vetted products. If it's not in there, and this book is updated every year or two, chances are it's a reason it's not in there. So I ask you to add this to your arsenal of resources for research. And you can just Google the exact word, German Commission E monograph, and it'll come up. I checked it. This is my natural aloha. No side effects.
Scott can take some questions if you have.
Hi. Yeah, I hear you said plant-based diets.
Earlier we heard about plant-based diet is recommended, and what do you tell Coumadin patients who are told not to eat dark green leafy vegetables?
Well, I'll tell you what I say. I'm not sure it's what.
Warfarin?
Yes.
Yeah, put it in context.
Yeah.
Right.
So she's asking what happened. What's my advice if she's on warfarin and takes dark green vegetable diet? Never is not my vocabulary. It's got to be a balance, and it's difficult to say no to everything that's green. But what you can do is consistency and moderation. And if you guys see it differently, please say. But I think if you look at reality in life, to say that I can never have a salad or I can't have spinach again in my life is unrealistic. But recognizing that what really happens is in seasons where vegetables come through harvest, that's where we see a problem. Everybody is diving into their gardens and having a feast. And that's a no-go. But going through moderation and...
So can I add just a little bit to that? If anyone, I think the question is, you're on warfarin, right? And warfarin, yes, and warfarin is a vitamin, not the other drugs that I mentioned. It's a vitamin, you know, that's where you get into the vitamin K antagonism. So
that's true.
So what I tell patients, Scott, is that as you're starting on warfarin, pick a diet you like. We can adjust it. You just, like you said, you can't go into a broccoli frenzy and then wonder why your INR suddenly plummeted, because it has a lot of vitamin K, and then that'll counteract it. That's the yin-yang, right? So Scott is right. I'll tell people you're starting this drug, pick a diet that you like, and then during that diet, we'll organize your Coumadin dose based on your diet. So you're right. You can't suddenly say, oh, man, look at this broccoli. I love it. Yeah, but you're going to be sorry 2 days later, right?
But you didn't say Brussels sprouts.
I don't like Brussels sprouts.
Another question.
Fire away.
Okay, so my daughter is on Coumadin because she has a heart valve. And if she eats broccoli, yes, her numbers will go down. And
her numbers will go down?
Her INR.
INR.
Is low. You know, and she really, really, really has to watch that. So from time to time, she has a little alcohol with that broccoli. But just trying to help regulate.
Well, I don't know if that's a question or just a statement.
Well,
I think
just saying, trying to balance out because she can't, it seems like she can't eat broccoli. So anyway.
So how about if we take this offline?
Yeah.
Okay.
And I'll talk to you as soon as we're done.
Great.
Okay?
That'd
I'll
be great.
talk to you.
Any more questions?
Yeah, any more questions for Scott? Yeah, we have one over there.
Fish oil. Can you
That's good.
comment
Fish
on
oil.
that?
Yeah.
You know, interesting, when I did this talk before, I spent a whole half hour talking about diets involving different types of fish. Polyunsaturated, the whole 9 yards. And fish is not equal to fish. There's different kinds. And buying these vitamins that are polyunsaturated fatty tablets, whatever, there's some benefit to some of these, but you got to be careful about where the source of the vitamin is. Happens to be that freshwater fish has stronger effects than saltwater fish.
I think what he's also asking is, we get this in the office too, how about taking supplemental fish oil? And if you do, how much the dose should be? And skipping
yeah, I'm not going to, as far as dose, usually it's in grams. Usually you have at least a gram or 2 a day.
Does it do anything?
Yeah, I think it does, honestly.
You do, really?
I really do. I think if you get a good, healthy fish oil, I think it does. Now,
the data are meager.
They are meager, but you know what?
We argue this all the time, yeah.
I'm not jumping the fence to the other side.
You retire and now you want to take the other side.
But I'll be honest, because you've asked me to do this talk how many times, I started to drink the Kool-Aid. No.
No. We have a question here.
Does it matter what brand of a supplement you buy?
I don't know how I can answer that. I can tell you that some brands have more reliability than others. They're higher quality brands. What you see lined up in the drugstore and Walmart and Target, it's hard to differentiate that. But some of the ones at the health food stores have been vetted better. And they're buying products that have, their labelings are more clear. They have resources to them. So there is a difference, I think, in brands, but I'm not going to be able to steer you to one or the other. I know for Q10, I could steer you exactly where to go because Q10 is just not that well absorbed. Only 1 or 2 companies make a product that is 30% absorption. I hear a train.
I think one last question. Oh, and then we'll take this question, and then one last one from that gentleman, and then we have to move on. So, yeah.
I'm a hiker, and a medical person on a hike once told me that to keep little packets of mustard in my pack, and if I had a leg cramp, to take the mustard. I thought it was a lack of water, but they said to take them because of the turmeric.
Hot dogs in there too? Or?
I'm not going to comment because I'm not sure I know. Do you rub it on? Do you take a pill?
No, on my feet? No. No, there's the turmeric in it, in the mustard. It's supposed to help with leg cramps. No.
I'm not going to say I know.
Okay.
We have one.
But I do now.
We have one last question way back over there. We'll get a mic to you right away. So I will say, while that mic's going there, I will tell you this. Commonly, to at least the cardiologist in our office, you will be on one of these things. We know the blood thinner interaction. Scott's really taught us all that. But I just want to tell you, when you ask us, will it interfere with the other medicines you're taking, I categorically will tell you I don't know. Because it's just not been studied. The stuff and you'll be on an antiarrhythmic drug. And there's very little room there. If you get too little, your rhythm comes back. If you get too much, you may have a fatal rhythm. So you just need to know, other than blood thinners, we really don't know.
No, the antiarrhythmics seem to continually pan out as being high interacting with these supplements.
Yes, you got to be careful. You got to be careful.
The biggest thing is make sure you tell us that you're on them. We're not going to judge you.
So before your aloha, you got one more question.
Okay.
You mentioned the essential oils. You had quite a long list there. Are you saying that they can be dangerous as an aroma or as ingested?
Both ingested and also applied.
Applied.
And think about it, if you inhale them, that's almost a direct conduit to your bloodstream, right?
Okay.
So if you inhale them with frequency and a lot, yes, absolutely. But it applies most if you're on a blood thinner. In the absence of that, probably not so much.
Well, thank you, Scott.
Thanks, appreciate it.
Did you stick around? It's been great everybody's been able to stick around. I apologize for, I left out this morning Oasis, who has been a great partner with us on this. I want to thank you for all your efforts. I appreciate that. I've talked to my buddies. Most of us will be able to stay around afterwards, so if you have some specific questions, we're willing to hang here at the table and talk to you after we're done. I put this in here because I felt of all the things you're going to learn today, it's probably the most important. I have been blessed with many wonderful nurses in my career, but none to the level of Marilyn. Some of you are my patients here, and you know that's true. And she just is really, if you are a physician and you have a great nurse working with you, you're home free. And I've asked her to really give you some key information of how to negotiate your office visit, because you need it. So Marilyn, it's all yours.
Thank you. Hold on. I'm going to say thank you to Dr. Prystowsky, and the world is a better place with him in it, for sure. But we'll have some fun, you and I. I'd be happy to take any questions. I'm going to give you some tips and hope they help. And then I know that you will all have some concerns of your own. I can't wait to hear. But I've got the hard subject, how to get the most out of your cardiology visit, or as I like to say, how to check your ticker quicker. So, something we all have in common. We're all patients. We're all in the same boat. Some of us are traveling first class. Some are down in steerage. But we're all in the same boat. And sometimes this is how our boat feels. We've got a lot of changes going on. Insurance is playing a heavier hand in what's going on with our health care. Things have gotten bigger and busier. And we've all gone computerized in the last decade. And these changes have made the waters very choppy, and things are going to continue to change. So we've just got to keep up with it. I know we're going to be all right because we have excellent physicians, we have the best health care, so we'll be all right. But we have to adapt to these changes. And that's my first tip of the day. We've got to become an active partner in our health care and help the doctor help us. We have to know our medications. We have to make sure our records are up to date, and I'm going to speak to that in a second. Know your insurance policy. Keep track of your signs and symptoms. If you have high blood pressure, go out and get yourself a cuff. Dr. Prystowsky spoke to some of the devices you can use to keep track of your heart rate. Keep regular follow-up. It is so much easier to treat an established patient than a patient that just comes in when they're having problems. And by all means, do what the doctor says. So as far as records go, our records are now out in cyberspace somewhere. I don't think they've been hacked yet by the Russians, but they're out in cyberspace somewhere. And I think of it like this bicycle wheel. Everyone should have a good primary care doctor who is your main doctor. And then any other doctor you see is the spoke of the wheel. All information feeds back to the main doctor. So a lot of our patients go to Florida for the winter or whatever, or if you see a doctor in another healthcare entity such as IU or community, they're going to send a summary letter back to that family doctor. But as you can see on a bicycle wheel, the spokes don't communicate with each other. So you say to me, but Marilyn, all my physicians are in Ascension Health, so our records should all be there. Well, this is true. But while you know that you need to import records from out of Ascension Health, even within Ascension Health, it can be tricky sometimes. Let's say you have a pulmonologist and a cardiologist, as well as your family doctor, but all in Ascension Health. In January, the pulmonologist has ordered a CAT scan on you or something, or chest x-ray. That pulmonologist will get the results of your test. He will then file it away in your chart. It is available in your chart, but it's filed away. So you see your cardiologist 5 months later, and you said, what'd you think of my CAT scan? And he said, well, I didn't know you had it. Because to look through every patient's chart would be a laborious task. You try to keep up, and you may run across it, but it's filed away. It can be filed away under many different things. So the takeaway from this is, if there's a test, procedure, lab work that is ordered by one physician, and you want another physician to see it, just call the office and let us know so we can let that physician open that up from your file and let the physician see it. Now, I went to Google, like we were talking about, everybody goes to Google, and they came up with some of these ideas to get more out of your office visit. And I highlighted number 1 and number 4. I especially love number 4. It says you have about 23 seconds to get your point across before the doctor takes over. And I said, uh-oh, that's got to be a typo. It should be 2.3 seconds. But it is true. It is true. You have an office visit. We allow in our office about 20 minutes for an established patient. A new patient gets about 40 minutes. And I think that's pretty generous. But it does go by quickly. And truly, there is a white coat syndrome that a lot of patients have, and they walk into the office and they just blanket over about what they want to say. So try to come prepared with what you want to get what your point is when you want to come in, because you do have just precious time with the doctor. Then number 1, current med list. Boy, I've been in nursing over 30 years, and this has always been a struggle in the hospital, everywhere. But this is the next helpful tip. Know your medications. Be specific and keep an accurate list. I did put don't rely on bottles, and it just happened this week. A patient is on a medicine, it's a calcium channel blocker, comes in 240 milligrams, 180 milligrams, 120 milligrams, and the dose has been changed, but he has kept all the bottles up in his cabinet. And he went home, filled his pill thing, called me about 2 weeks later and said, I have no idea which one of these I'm supposed to be taking. So keep a master list and be specific. And then I'm glad it's after Scott's talk, because it points out how there's so much interaction between medication, and you have to have a complete list. I use this as an example, a beta blocker. A very common medicine, a very good medicine that is used by cardiologists, used by family doctor. You can see it has a variety of reasons to be used, but it has all these different names. And I think one of the reasons that medications are such a challenge is because these names are so unfamiliar to us. They don't sound like English words, and people call up and say, I need a refill on my C medicine, because it was C. So it's just important to keep a list. I know it's a pain, but keep a list in your wallet with you at all times, and make it as complete as you can. Now, I went through and asked everybody in the office what some of the issues in our office were, and I asked as many patients as I could, what are some of the issues? And we have a lot of issues, for sure. We have started an interdisciplinary team where we're going to try to parse out everything from parking all the way, to should we have a vending machine in the waiting room or whatever. But by far and away, the 3 biggest concerns were waiting, scheduling, and calling in. So I'll start with those. I'm going to do those 3. Waiting. Nobody likes to wait. And we always blame this on the doctor, but I'm going to give the doctor a pass, and I'll tell you why. They start their day very early, and they end their day very late. They very rarely get lunch. Their reasons for being late are usually pretty legit. And it's very hard to predict a patient day. And the doctor will give a patient the time they need. We allow this 20 minutes, but if they need more, the doctor will give it. So I'm giving them a pass. But I tried to look for other areas where a patient might have to wait in the office. And this is our process. And I think it's true for a lot of offices. The process is very similar. But you come in and you sign in on a sheet, and then you go sit down and wait. And then you have to go get checked in, and then you sit down and wait. And as you can see, that's a big wait usually. And then you get called back to the back where you are processed. They go through your medications, make sure your medications are right, and then you wait to see the doctor. There is a huge bottleneck at check-in. And the reason for this is really pretty simple. We have, as I said, bigger and busier offices, but in our office, there's probably 10 to 15 doctors a day that are seeing patients, and we have 2 to 4 check-in people. So there's a bottleneck there, and mistakes are made. They're not life-threatening mistakes, but mistakes can be made. The only way we know in the back that you're ready is when the check-in person checks you in. Last week, somebody was checked out before they were checked in. I'm not kidding. So, so this, I think, is something that we can work on for sure. We have thought about doing a kiosk like they do in airports and different ideas. But this is, and if you have ideas, I'd love to hear. But this is an area where we can certainly work on. But here's my next tip. If you feel comfortable, if you can, use the patient portal. All offices have these now. And I know ours takes some work. I think there have been some changes that are going on with it. But this is so valuable. You can see your lab results on the patient portal. You can request an appointment on the patient portal. You can send messages to the nurse and the doctor on the patient portal. And you can check in early on the patient portal. So if you can do all of this on the patient portal, go to your office visit, and there's nothing new that you need to talk about there as far as check-in goes, they can mark you checked in. It shortens that process down. Now, I also put down schedule early in the day if you don't want to wait. Earlier appointments usually don't have to wait as long. Our big waits seem to be in the middle of the day. Try to allow time. If you're scheduling a hair appointment at 9 and your doctor's visit's at 8, you're going to feel rushed, you know. Prepare. And ask the front desk if you've been waiting. I say more than 15, 20 minutes. Ask the front desk if you're waiting. It will do two things. It will ensure that you've been checked in properly, and it will also, they'll call back and ask us, and we don't mind, and we'll tell you how long you have to wait. It may only be 5 more minutes. You're going to feel a lot better. But keep in mind, we take people in the order of their appointments. So if you get there a half hour early, and Joe Smith comes in later, and he's only 1 minute before his appointment, we're still going to take him if it's time for his appointment. So just keep that in mind. Now, scheduling. This isn't really too far off from the truth. If you call the main, and that's our switchboard number. That's just for cardiology switchboard number. If you call them for a non-urgent appointment, you're going to get an appointment. But it's probably going to be 2 to 3 months out. And that's okay. You should call the main number for an appointment. We don't want to bog down the nurse line with scheduling necessarily. However, my next tip, if you need an appointment because you have a medical concern and you need to get in early, the doctors want you to be seen. They want to get you scheduled, and we're going to work with you to get that done. But here's the trick. Call into the main number, ask for your doctor's nurse's line, and be specific. We have 2 Dr. Patels that work in our office. Be specific who you want. Every nurse has a dedicated phone line at our office. So you will get connected to that phone line. It will probably go to voicemail. Leave a message. I know the nurses I work with, we are very good about calling people back. I'd say 99.9% of the time we will call you back before the end of the day, but usually within 1 to 2 hours. So leave a message, know that we'll call you back. Now, what if you really have to talk to somebody? And this we hear so often. It's very difficult for us to be standing by the phone answering calls all day long. But if we are by the phone, we'll pick up and answer the phone. So seems to be a big problem in our office, the robocalls and the callbacks. Like I said, if you need to talk to someone, leave a message. Then, if we call you back, beware that the number will scramble on your phone. It won't look like the number that you called. Very often, it will have a 713 prefix. This is for Ascension Health. But it may have a different prefix. But the point is, you're not going to know the number. Now, we are working to have that number, put a St. Vincent on there, so at least you know it's a doctor's office. But it's going to scramble, so please answer your phone if you're expecting a call. If you don't want to answer your phone, give permission for us to leave a message. We are very serious about the Privacy Act, the HIPAA Act, And we will not leave a message, even with your spouse that you've been married to for 68 years, if he or she is not on your privacy list. So give us permission and we will leave you a message, but answer your phone. If you're expecting a call, please. Or use the patient portal. So helpful tips in summary. Messages left on the nurse's line will be answered relatively quickly. Remember that. Now, if you have truly got an emergency, you may have to go to the ER. You may have to call 911 if it's really, truly bad. And emergencies are not needing a refill, but things where you are physically feeling bad would be an emergency. Call the switchboard and state that you have an emergency and you cannot go to voicemail. And then they will put you through to the back where someone will talk to you. That might be the end of my talk. Now here's someone who is not using my helpful tips. She's a mess. So this could be you. But here's someone who is using my helpful tips, and she is now a famous movie star. So these are my summaries. Who's got questions? And please tell me things that we can work on.
You have questions for Marilyn? So I will say one thing. I want to stress one thing Marilyn said. The commonest complaints we get, especially Dr. Herms and I, because we have sort of super specialties, and it's hard to get in to see us. We understand that. And we'll see someone at a party, right?
Oh,
and
yes. Yeah.
And they'll say, how come you won't see my aunt for 4 months? And I said, well, who'd you call? Routine scheduling. I said, well, let me give you Marilyn's number. And most of us, as busy as we are, if we need to see someone, if a doctor says we want to get them in, almost always we'll be seen that week. Sometimes that day or the next day. We're not scheduled for that, but we understand that. If a doctor calls Marilyn and says, you know, hey, can Eric see this person in the next 24 hours? We'll add them on. It's as simple as that. We won't bump everyone else, but we'll add them on at the end of the day. And we do that with each other. We text all the time. So take what she said very seriously. Don't get frustrated that you're not feeling well and you wait 4 months. You don't have to wait the 4 months. Call the nurse of the doctor, and you'll get seen quickly. That's probably the most important message that Marilyn's given you today.
But I'd love to hear if there's things we need to work on. I know there are. If you've got any, let me know. Come on, I know it's not that good. Yeah.
Well, I've used the patient portal and it gives me an appointment time that's recommended and everything. Then it kicks me right back out and I start again.
Yes, it needs some tweaking. And she was saying she was having trouble with the patient portal and being able to schedule. I have been told you can request an appointment on there, but you cannot schedule because cardiology is a specialty and it requires a little bit different operation of scheduling than such as at a primary care doctor's office, which I have scheduled those on the portal. I don't know if any of you have had any trouble doing that, but that's what I've been told. You can request an appointment only. But that's good to know because I'm on the team and I'm going to bring that back to them. And I know it is undergoing changes constantly. And I've heard we've added new questions now when you sign in and some funny questions, but yes.
There's one.
I just have a comment. I want to thank you for sharing that you might get a call back, and that number is. I want to thank you for sharing that when you get a call back, it might be a scrambled call.
Yes.
Robocalls are so frequent. I called and kept getting this throughout the day, this odd number, but I had no idea that it was St. Vincent calling me back because I was expecting them to call on the same number.
Right.
And so it's helpful to know that. It might be helpful, too, to just put on the voicemail. When you get a call back, it might be from a 713 number. That is a St. Vincent number. Just so that people can be aware.
Idea, yes.
Because I could have gone, matter of fact, I called the doctor's office back and said, you know, I called 5 hours ago and I'm still not hearing from you. And finally, the nurse says, well, I've called, but nobody's answered. Well, so anyway, thank
That's
you.
an excellent idea.
Thank you.
That's an excellent idea. I appreciate that.
Other comments, concerns? Thanks, Mary.
Thank
Great
you.
job. I have a test for you right down there on my thing. So, a couple things. As I said, some of us are going to stay around because I have nothing else to do today. No, but we're going to stay around, and we're happy to take your questions and concerns. This is, I told you this morning, this is the first time I've ever done this. I've spent the better part of my career doing programs, but they've all been for professional groups or trainees and things. So we really do want to hear back from you. I need to know, I mean, this is sponsored by foundation money, and people give their hard-earned money to go into patient education. I'm thrilled with the fact that so many people came and stayed the whole time. But we want to know what you thought of it. Please, Susanna, what's the best way to hear back from folks? And also, what other topics you might want to hear about in the future. I'm involved now with developing a teaching video for AFib that I hope will be probably the best one in the world. We've got, most of the money, believe it or not, is trying to get the video right, trying to get a moving heart and stuff. And then I know Dr. Hermuller is going to be delighted to do one in his area, and we have the money for it. I mean, that's what the gracious gifts are going to be used for. But we need to know from you what works. This is the first time we've ever done this, and it's really important to get feedback. And if you don't worry about hurting our feelings. We want to know what worked, what didn't work, and what you want to hear about. Was there a comment somebody had? Yeah.
Who's your cardiologist?
I go to the smartest cardiologist in the world. I treat myself. No, I'm my PCP's worst enemy. And actually, one of my closest friends who was here earlier told me a story, and I chuckled. I said, yeah, I get it. If you're really kind of in the know, you know what to do. So I'm also, don't forget, cardiologists start as internists, and then they become a cardiologist. So 3 years of internal medicine, 3 years of cardiology, 2 years of electrophysiology, 4 years of medical school. So it's a long haul. Herms is interventional. Emily is general cardiology, and Kathy's endocrinology, but it's a long haul, right? So I'm also an internist. So I kind of know what to do. So if I have a GI problem, I call my gastroenterologist. If I have a GU problem, I call my urologist. So cardiology, I'm pretty good on. So I don't think I have to call anyone on cardiology. But I will tell you what I get asked all the time, and I'll bet you these people too. They'll say, well, Dr. P, who can I go to for, I have a prostate problem, And I'll say, well, there's a lot of people. I'm not here to recommend. They say, who do you use? Because they figure you probably use the one I should use. So I am willing to give out those names. And usually I'll give you the backstory number because they're all friends of mine. I'll just say, tell Merrick told you to call. And you'll forget the 6-month wait. So, but I will say another thing I should tell you, especially older men in the room. A common cause, I didn't mention this earlier, of dizziness. You get put on some of these prostate medicines that drop blood pressure. And you get up to go to the bathroom at 3 in the morning, and don't be surprised after 4 steps you're on the floor, okay? So that isn't time to call the emergency room. Usually it's a blood pressure issue. So do understand with any of these, a valuable thing to tell your doctor is any new drugs you're taking before you develop symptoms, right, Emily, Kathy? Because like Scott pointed out, it could even just be some crazy supplement that your buddy told you to take. That could interact. That could make a difference. And we're trying to go down this road of sensible medicine. We don't want to do 30 tests if we don't have to. But you got to give us that info. Don't say, oh, I forgot to tell you about this. What's that, Scott? Some Chinese drug, really? But I wouldn't even know what to do with that. But I would Google it and say, what the heck is this? And say, oh, you were fine until you started this? Guess what? This is simple. Stop the drug. It's not a drug anyway. Just stop taking it. So. But really, we would love to hear back from you. Thank you all. Have a wonderful weekend. Appreciate your coming.